Namaskar and good evening, everyone. A very warm welcome for the webinar on Revisit ASCO 2026 Practice Changing Updates in GI, GU, and Gynecological Cancers. With immense pleasure, I would like to invite convener of the program, Dr. Sachin Gupta, who is Director in Medical Oncology and Hemato-Oncology, Max Super Specialty Hospital, Mohali, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
Yeah, thank you, Ekta, and thank you, Horizon, for helping us organize this webinar. So this is a 2 days proceeding, about 2.5 hours each day. And so we are trying to cover some important information which has been gathered recently in last few months, mainly coming from ASCO, uh, sub-site specific conferences. And so we are going to cover a little bit of prostate cancer, then also gastric cancer with use of immuno-oncology drugs in gastric, esophageal, and there is, and of course bladder cancer also. A lot is happening in this space as well. And renal cancer also we are covering broadly the role of IO drugs, and also some there's a panel discussion on sequencing in metastatic RCC patients. And many exciting things are happening in the endometrial cancer also. We know the molecular biology is actually playing a very important role in endometrial cancer these days. And so there are some immunotherapy drugs which have come up, and the usage is increasing, and we are seeing better responses, and our patients are benefiting from this. So that also we're going to take up. And there is role of liquid biopsy in CRC, which has come up a lot. That also we are going to take up. And there are so few abstracts and some more lectures on colorectal also. That also we are going to cover. So that is mainly tomorrow. So without taking more time, I think we should start with the first lecture now. And my very dear colleague, Dr. Sajal Kakad, is already here with us. And Dr. Sajal is a expert radiation oncology. He's director of radiation oncology department at Max with us. And he'll be speaking on primary results from NRG GU 005. So this is a phase 3 trial of SBRT versus hypofractionated IMRT for localized intermediate risk prostate cancer. So this is again a very important area. We are seeing a lot of early prostate cancer these days, and radiation is a very important aspect of treatment of early prostate cancer these days. And Dr. Sajal will throw some light on this particular abstract. Over to you, Dr. Sajal.
Thank you, Dr. Sachin, for kind introduction. Very good evening to all of you. I hope I'm audible to everyone.
Yeah.
So I'll share my screen now with the presentation. Is this visible? The slides are visible, I hope.
Yes, yes.
Sir.
So thank you, Dr. Sachin and entire organizing team for this program. And I'm really excited to present the data on this much anticipated randomized trial on prostate cancer. Basically, NRG GU 005 is a phase 3 randomized trial that compared stereotactic body radiotherapy with hypofractionated IMRT for localized intermediate risk prostate cancer. It was presented in plenary session in abstract form in ASTRO 2025 by the principal investigator R.J. Ellis. So it's a multicentric randomized trial. So basically, intermediate risk prostate cancer have excellent outcomes, and there are multiple different type of fractionation protocols in intermediate risk prostate cancer. It can be 20 fractions like famous CHIP protocol, 25 fractions, 28 or 35 fractions. And in 2024, PACE B randomized trial has proven non-inferiority of stereotactic body radiotherapy over hypofractionated IMRT. So the basic premise of GU005 was to prove superiority of SBRT over hypofractionated IMRT in intermediate risk prostate cancer. So this trial had two primary endpoints. One was to determine if SBRT is superior to IMRT in terms of patient-reported GI and GU toxicity at 2 years post-completion of therapy by minimal clinically important difference score analysis in EPIC 26 questionnaire. And the another co-primary endpoint was to determine superiority in terms of disease-free survival. And important to note is it is patient-reported quality of life, not the investigator-reported quality of life, which is a more better and stringent outcome of quality of life if a patient is reporting whatever he is experiencing post-treatment. So 698 patients of intermediate risk were randomized from between 2017 to 2022. The stratification was on the basis of Gleason score and PSA, PSA being between 10 to 20 and Gleason score 6 or 7. Another stratification was whether rectal manipulation was used or not. Now, what is this? Basically, a physical medium was inserted between prostate and anterior rectal wall so as to push the rectum away from the prostate or the target area and hence to reduce the rectal toxicity. So it was used or it was not used. And then there were two in the control arm, there were two fractionation protocols for IMRT. One was in 28 fractions and the other was in 20 fractions. So the randomization, as you can see on the right side, the first arm was control arm is IMRT with two different fractionation protocols. And if you can see the margins which were used was 8 mm expansion all around and 5 mm posteriorly. Obviously, rectum is on the posterior, so we have to be a bit more careful for rectum. Stereotactic body radiotherapy, that was second arm. The treatment was delivered in 5 fractions over 1 to 2 weeks, that is every alternate or every 2 days. And here the margins were further low, 5 mm all around and 3 mm anterior and posterior. So margins were further reduced in the SBRT arm. Now, if we see one of the primary endpoint, that is disease-free survival. So if you can see, the disease-free survival superiority was not met. So SBRT was not superior to IMRT at 5 years. So, and why this happened? This happened because the biochemical failure rates increased at 3 years in SBRT arm, and that was clinically significant. Now, why this happened? Whenever the full text is published and we have further mature data, probably we'll come to know why the PSA was rising in the patients at 3 years. And hence the overall survival was also similar. And it was better in IMRT, but that was obviously statistically not significant. Now coming to the other primary endpoint, that is quality of life, bowel outcomes, that is rectal toxicity, were reduced in SBRT arm. So one of the primary endpoint was met. Overall urinary toxicity or irritation that was not improved significantly in SBRT. But if we see the secondary endpoints, so in the secondary endpoints, sexual and bowel related quality of life at 1 year were better in SBRT arm, and urinary incontinence rates quality of life was better in SBRT at 2 years. So hence we can say that SBRT is pretty safe for the treatment of intermediate risk prostate cancer and associated with low quality of life scores or low toxicity. To conclude, as I have told you, PACE-B has already established that SBRT is non-inferior to IMRT, but this GU005 has shown that SBRT is better as far as rectal toxicity is concerned. It has also shown that secondary endpoints of urinary and sexual outcomes were better in SBRT arm. And this is the first prospective randomized trial which has shown that introduction of rectal spacer further reduces rectal toxicity in both the arms, whether it is IMRT or SBRT. Authors have proposed probably further micro-boosting the intraprostatic target may improve the disease-free survival as has been shown previously in the FLAME trial. So with this, I would conclude my presentation. And any questions I would be happy to answer. Thank you.
Yeah, Dr. Sajid, you can keep this last slide displayed as of now. So this rectal spacer thing, are we using this? I am not aware of
the rectal spacer is not being used so much in the various radiation oncology departments. In India, hardly, I think Apollo Proton Center is using it very regularly, but it is not being used much. There are a couple of reasons. One is the cost, obviously, because it costs almost 1.5 to 2 lakhs this procedure, to put this rectal spacer over and above the radiation cost of the radiation treatment. And this is an invasive procedure. Either a
Yeah.
radiation oncologist or an intervention radiologist or a urologist in operation theater, they have to place this spacer gel in with a transperineal approach. So it's an invasive. And if it is not done properly by an expert, it can itself cause rectal ulcerations, rectal fistula formation, or
There must be complications with this,
yes,
right?
or misplacement of it is not, probably sometimes it is not placed where it should be. And it is used only in the low and intermediate risk, because in our country we have more of high risk population, high risk patient with extra prostatic extension, very close to the anterior rectal wall disease. In that we can't use it, because then probably we will be missing the target. So, and we have seen, if we follow our traditional rectal protocol, that is, we empty our rectum with the help of enema or laxative and do the treatment, we get acceptable, reasonable quality of life even without using this spacer. So that's the reason why the spacer use is not very routine in the various departments.
Okay, so now you have both the facilities available with you in department, SBRT and
Yes.
IMRT. What
Yes.
is your preference with these newer information? Are you keen to
So
use SBRT
no,
or
no,
you
yes,
stick to
yes,
the
yes.
traditional?
For intermediate risk and low risk, obviously, we obviously prefer SBRT over IMRT, only for the simple fact that the treatment is done just in 5 sittings. So in
Mhm.
10 to 15 days, the entire treatment is over, because treatment is done every alternate day or every 2 days. And it has been very clearly shown this is non-inferior to the traditional IMRT protocols. But only important point is we need to be very, very careful and are confident enough about our image verification during the treatment, because
Mhm.
we are dealing with very, very high doses. We need to have uniform bladder and rectal volume during the treatment. And obviously strict protocols should be followed so that we should not miss the target or treat the normal tissues, expose the normal tissues to a higher dose. So it can be a double-edged sword if not done properly.
So, okay, that's great. Any other question? Dr. Rishabh, Dr. Kanupriya, Anuj, any questions for Dr. Sajal? If not, then we can move on to the next. Oh, thank you, Dr. Sajal,
Thank
for
you,
that
Sachin. Thank you.
beautiful presentation. I think a lot to learn here using SBRT in this space. And thank you so much. So I'll invite Dr. Rishabh Jain,
Thank you,
who
Sachin.
is already joined here with us. So we have another phase 3 study. So this is again, we are dealing with prostate cancer here. Dr. Rishabh, the stage is all yours. You can share your presentation.
Thank you, Dr. Sachin sir, and the entire team for giving me the chance to present here. So today I'll be presenting the Capitello 281 trial, which is the patient-reported outcomes and tolerability of capivasertib plus abiraterone versus the placebo versus abiraterone patients with PTEN deficient metastatic HSPCs. So as we all know that the PTEN proficient hormone sensitive tumor cells, AR signaling is the key driver for proliferation. But in the PTEN deficient tumor cells, there is an additional proliferative drive from upregulation of PI3-AKT pathway that complements and provides an alternate survival mechanism to AR signaling, as can be seen in the diagram. And PTEN deficiency is definitely associated with a poor prognosis, as has been seen in the various retrospective analysis. Also, capivasertib is a potent selective inhibitor of all three AKT isoforms, which are AKT 1, 2, 3. And the phase 2-3 evidence showed benefits with epatasertib plus abiraterone PTEN deficient metastatic CRPCs. And hence the Capitello 281 trial was designed. It was a global multicenter randomized double-blind phase 3 study in which the patients with PTEN deficient de novo metastatic HSPCs were taken. And the important point to note is that the PTEN deficiency was labeled as the diagnostic cutoff of more than equal to 90% of viable malignant cells with no specific IHC, which means less than 10% should be expressing the PTEN by IHC. And they were randomized into two arms, which was capivasertib plus abiraterone plus ADT versus a placebo with abiraterone and ADT. The primary endpoint were investigator-assessed RPFS, and the secondary endpoints were OS, time to first subsequent therapy, symptomatic skeletal event-free survival, and time to progression. And an interesting point to note in this trial was the patient-reported outcomes or the tolerability endpoints, which were FACT-P, AE assessment, and PGIS. So when we look at the study and the results, we can see that the capivasertib arm had a PFS benefit of 33.2 months versus a placebo of 25.7 months with a hazard ratio of 0.81 and a p-value of 0.034, and hence it was significant, as can be seen in these Kaplan-Meier curves. Also, when subgroup analysis were done, it was seen that it showed benefit in all subgroups, more so in the patients who had 100% result, 100% efficiency. As we can see, the 90% curve, the 95% curve, and the 99% curve, the gap is widening and widening and widening. And hence, more PTEN deficient you are, more this drug works, was what proved in this trial. And definitely 100% cutoff had the best responses. Also, we can see that the patient-reported outcomes were included in this, which include the famous FACT-Piece questionnaire, which includes physical well-being, functional well-being, emotional well-being, social well-being, and the prostate-related symptoms. So, as we can see, the FACT-P questionnaire, the physical well-being, both the curves are overlapping. And the adjusted mean for capivasertib arm is minus 1.7 versus placebo arm is minus 1.3. And a small difference of 0.4, which is doable because this is not very significant. Also, when we can see the time to clinically meaningful decrease in FACT-P scores, it is also not much, and hence it can be tolerated with proper efficiency. Also, when we can see the functional well-being, again the story remains same. Capivasertib with -1 and placebo with -0.7, a difference of 0.3 which is negligible. Same goes with the total FACT-P score, which determines that the patients did not have much of a decrease in the FACT-P score, and the patient-reported outcomes were okay as compared to we are giving a toxic drug. Also, when we look at the safety summary, the patients having any side effects were 98.8% versus 92% placebo. Adverse events were a bit more, which was 67% in the capivasertib arm. The patients did discontinue capivasertib, but as we can see in this graph, the discontinuations of capivasertib due to AEs, when necessary, occurred early with the majority, occurring within first 3 months. Hence, the patient, if tolerated after 3 months, it will more he or she must more likely tolerate the drug in the future also. When we look at the adverse effects, as expected, these were diarrhea, hyperglycemia, and rashes, and they could be managed easily clinically. And definitely the adverse events were more in the capivasertib arm, as can be seen in this table. So to conclude, the Capitello 281 did meet its primary endpoint, showing a statistically significant RPFS benefit with Capi plus AB. The median RPFS was 33.2 months versus 25.7 months. And the post-hoc analysis at increased PTEN cutoff showed greater treatment effect with Capi plus AB. Also, the common adverse events associated were AKT inhibition, diarrhea, rash, and hyperglycemia. And despite more AEs in the Capi plus AB arm, addition of capivasertib did not affect other functional aspects of the patient life, like work, sleep, enjoyment of life. And overall, quality of life remained okay. So, capivasertib in combination with abiraterone represent a potential first-in-class targeted treatment for the patients with PTEN deficient metastatic HSPCs for now. Thank you.
Thank you. Thank you, Dr. Rishabh. Do we have any questions regarding this?
One question I just had, a short one. Thank you,
Yeah.
Dr. Rishabh, for this presentation. I had one query. So you showed that PTN more than 90%, more than 95% should be reported. So
Yes,
is this consistently reported all across by the labs, PTN loss more than 90%? Because then only it has shown to be effectiveness, the drug.
Sir, IHC, the problem with IHC is a bit subjective. So essentially more than 90% we are telling almost all is gone. So definitely inter-lab discrepancy will be there while reporting IHCs, and that is a drawback of doing IHC in any case.
But are we doing it, Rishabh? I don't think in clinic we are ordering
No,
this
sir.
test.
Not as of now, we
This
have
is a
not
very
started yet,
recent
sir.
information. Nobody is actually doing PTEN ISC. I've never ordered it.
Currently, no,
And
sir.
this drug is not available freely to us. It's a costly drug.
Yeah.
Okay.
And another question is, so till now we are stratifying. So if we get a metastatic CSPC or other situation, so we are initially we are going to treat with ADT plus abiraterone or enzalutamide or plus minus docetaxel. So how do you fit this information into the algorithm?
Sir, the PTEN deficient prostate cancers are a bit rare. It's around 7 to 8% of all prostate
Yeah.
cancers. And the analysis have shown that only abiraterone, as we know, because of the mechanism also, that it's not only androgen dependent. So only in these subset, special subset of patients, I think PTEN deficient, like she should be targeted.
So we are sort of with this abstract, so we are sensitized to look at PTEN deficiency also in future and bring this drug. So at some point of time these drugs would be available.
Yeah.
So then the algorithm would be something like using, let's say, olaparib upfront, like capivasertib upfront in combination with abiraterone or enzalutamide, or apart from ADT, or use chemotherapy in where these things are not applicable. So the treatment algorithm is going to change in next few years depending upon the whatever targets we get upfront. That's how I envisage this.
Yeah.
Any more thoughts about this from your side?
Yeah, definitely that paradigm is changing and we might see more markers coming up in the near future. But currently, as PARP inhibitors, as you rightly said, sir, we might be testing for PTEN more often in coming years.
In coming years. And let's hope these drugs become cheaper and more affordable and available.
Yeah.
All right. Thank you. Thank you, Rishabh, for enlightening us on this topic. I think so many things are coming up. So we need to, yeah. Any question?
So for the next session, I would like to invite you.
Yes, yes, yes. All right. So
It's
let
a
me.
sponsored session by AstraZeneca. Dr. Sachin Gupta is going to present that. He's Director Medical Oncology and Hemato-Oncology, Max Super Specialty Hospital, Mohali. Over to you, sir.
Thank you. So I want to share my slides. All right. I hope you can see the slides.
No, sir, not yet. सर आप अभी शेयर नहीं किया है आपने स्क्रीन अपना
नहीं हुआ मिनट now I hope it's there now, right?
Sir, it is coming, but not yet. Yes, sir.
Yes, now it is visible.
It is visible.
Sure, but that's fine. So I think we are already now delayed by 5 minutes. I'll have to be a little quick. So now gastric cancer, this space is also buzzing with a lot of new information. So many drugs have come up, and so we'll be sharing some data in resectable gastric cancer. So this is like perioperative chemo, and so we'll be discussing this under these headings. And so this is one of the most common cancers and one of the most common fatal cancers actually. This used to be called as Captain of Men of Death in Love and Valley textbook, if you remember. And second most common GI cancer, and majority these are adenocarcinomas and male preponderance. And if we look at the outcomes, the 5-year survivals and the outcomes are still dismal. And yeah, I want to hide this panel. Huh? This is not going. Okay. So okay. Now we know the very early stage gastric cancer can be endoscopically resected, and mainly stage 2, 3, and up to 4A, there is role of perioperative chemotherapy, and of course we do surgery. And then we have advanced gastric cancer, which require mainly systemic therapy. So any T2 and above or any node positive disease would be eligible for perioperative chemotherapy and IO. And post of chemo radiation if there is less than D2 resection, and post of chemotherapy after primary D2 dissection. So this is the broadly consensus which we follow most of the times. And but majority of these patients are having recurrences, and if we look at these pie diagrams, so recurrence after surgery is very common to the tune of more than 60%, and a lot of these recurrences happen within 2 years, so nearly 43%. And so this is a highly unmet need, and we need much more improvement in the management of these cancers. If you remember, MAGIC trial was there many years back, where perioperative ECF therapy versus surgery alone was compared, and we found that PFS and OS improvement happened with addition of perioperative chemotherapy, namely ECF regime. And if we look at the OS, it was 36% 5-year OS versus 23% with hazard ratio of 0.75. So then came the FLOT 4 study, where FLOT was compared with ECF or ESX, which was the standard at that time. And so 4 cycles of FLOT surgery followed by 4 cycles adjuvant FLOT. And here, if we see, there was further improvement. So FLOT fared better than ECF. So now this became the standard of care. Perioperative FLOT till recently was the standard which most of us were following. And median was 50 months versus 35 months, and PCR rate of 16%, which was sort of unheard of in this particular cancer. And the toxicities were well managed and well matched, and our patients could take FLOT. Most of them were handling it well. And 87% completed NACT, 77% completed adjuvant treatment also. And so this was feasible with high completion and manageable toxicity, and early survival outcomes were similar to the FLOT AIO study. And so the modified FLOT is what we are going following now, where it is given over 46 hours rather than the original day one 24 hours regimen. So something like FOLFOX, right? So we give 5FU in that fashion. And so this is perioperative modified FLOT versus EOX, results of matched pair analysis. So curative resection M-FLOT is 86% versus 76% with EOX. So M-FLOT has better survival outcomes with tolerable safety profile. So this became the standard. So modified FLOT is what we do. And but still, in spite of this improvement, there are still many recurrences, and disease comes back. There are progression, and ultimately we lose so many of these patients. Now came the role of perioperative IO, so which immunotherapy primes systemic immunity by exposing tumor antigens, clears MRD by T cells, and builds immune memory for long-term cancer surveillance. And a lot of these cancers would be PD-L1 positive, and high PD-L1 gastric cancers are having lower 5-year OS than the low PD-L1. So this is a sort of poor prognostic marker if PDL overexpression is there. And these are the some of the trials in this space. Keynote 585 was with Pembro, Matterhorn is with durvalumab, then there is a atezolizumab trial, and there is a attraction trial with the adjuvant nivolumab. Now, if we compare these trials according to the endpoints which they have chosen, Matterhorn containing FLOT plus durvalumab is the only trial which is showing this PAT-CR benefit along with EFS benefit and OS benefit. So this is why this particular regime scores over other regimens. This was a phase 3 nivolumab plus chemotherapy as post of adjuvant treatment in stage 3 gastric cancer. And this study did not meet the primary endpoint of recurrence-free survival. And keynote, the pembrolizumab trial. Now in this trial, what has happened is the chemotherapy arm they have chosen was very heterogeneous. It could be cisplatin capecitabine, it could be cisplatin 5-FU, or there were some patients with FLOT also later on, because then FLOT became the standard of care. Then they added this regime also, and then they gave perioperative 4 cycles followed by more chemotherapy after surgery, and pembro was continued for entire year. Although this showed improvement in PAT-CR, but this does not translate into a significant improvement in the median EFS. And there was no statistical improvement in OS compared to only chemotherapy. But maybe, the reason could be a lot of heterogeneity in the chemotherapy arm here. And so now this Matterhorn data, when it came, this got FDA approval for resectable gastric and GE junction. And if we look at this study design, so T2 and above, and any node positive non-metastatic gastric cancer, and stratification according to geographic region, lymph node status, and PDL1 expression less than 1 versus more than 1% TAP. So durvalumab is given once a month, and FLOT is given twice a month, 4 sessions, followed by surgery, followed by more chemotherapy, same as pre-op, and durvalumab is further continued beyond that. And primary endpoint is EFS, secondary is OS and PAT-CR. And majority of these patients completed surgery, and R0 resection 92, 77% received adjuvant, and 52% completed durvalumab, and 61%, 64% completed any FLOT. And if we look at the tumor site, mainly gastric, 68%, and T4, 25%, 69 were node positive, 90% were PDL1 more than 1%, and MSI high were only 5%, and majority were non-MSI high, and some were having not evaluated for this. And intestinal 50%, and diffuse is about 27%. So these are the main things we have to look into this. And now coming to the EFS, so these curves are divergent, well divergent early on, and 24-month EFS 67.4 versus 58. So there is a clear difference, and these curves remain divergent later on. And forest plot favors durvalumab plus FLOT across all subgroups, except for this diffuse type of histology. So there the this line doesn't is not crossing that much. Otherwise, in all other areas, it is making showing good benefit here. And this is the OS. Again, the curves remain divergent. If we see the median OS not reached with versus nearly 40 months, hazard ratio of 0.79.
Sorry to interrupt
So,
you. Please
yeah. Time
conclude
up?
the session in 1 or 2 minutes.
Yes. Yeah, we're already. So again, except for diffuse histological type, and in all other areas, there is benefit. And this is according to the PDL1 status. So irrespective of PDL1 status, benefit is nearly similar. And PAT-CR is 19%. So this delta is again of 12% is impressive with this regime. And PAT-CR response and EFS. So again, with any pathological response or total pathological response, the benefit is still there. A majority patients could finish the treatment. And safety profile, if we see, this was well tolerated. No additional major issues with this. It did not delay surgery, and a lot of patients could complete their treatments. These are the common adverse events with this. So we can say this Durva plus Flot improved OS overall and event-free survival in resectable gastric and GE junction adenocarcinoma. And so this has become a new standard of care in these patients, and we are using this more and more in such resectable gastric cancer patients. Thank you.
So thank you for the excellent talk.
So we can have, do we have time for questions? Maybe one.
Sir, I think we can invite our next.
Yeah.
Dr.
I think
Sachin,
this was clear. I think most of us would agree with this data. I think this is impressive.
Sachin, how many patients we have used Durva for gastric
So
patients?
we have few patients only, not too many. This is in single digit, but we are actually getting good paths here. A couple of them have achieved paths here, and tolerance was excellent.
So after the perioperative treatment, do we continue durvalumab for
Yes, for a year.
later?
Yes, we continue.
And tolerance is good because the study shows there's a lot of adverse events, grade 3, 4.
So they were, but they are usually, you know, the chemotherapy is also responsible for a lot of these agents. But durvalumab, I find it adverse event wise, it is a pretty good tolerated drug.
And
No
post-op
major
also,
issues, at
plot
least
was,
in. And
post-op plot was also given for 4 cycles?
yes, 4 sessions, yeah.
Okay.
All right, should we move ahead? So
Yes,
I
sir.
invite Dr. Akanksha Chabra, who's a consultant medical oncologist at Max Hospital in Mohali. She's my colleague here now. She would be delivering a lecture on enfortumab vedotin in relapsed refractory bladder cancer. So now this is another space where ADCs, IOs, they are making a lot of difference in the outcome of patients. Dr. Akanksha, you can share your slides now.
So, a very good evening to all. Thank you, Sachin sir, for giving me this opportunity. And thank you, Estelas, for inviting me and sharing the slides with me. So, the slides are provided to me by Estelas. And I would be talking on enfortumab vedotin in relapsed refractory bladder cancer. So, these are my disclaimer. So, whenever we talk about the treatment of urinary bladder cancer in the first line, our mainly go-to therapy is platinum-based chemotherapy, which is cisplatin-based, along with PD-1 or PD-L1 inhibitor. But in real practice, up to 50% of the patients, they are unfit to receive the platinum-based chemotherapy or they are cisplatin ineligible. And whenever we give platinum based chemotherapy, majority of the patients, 50% of the patients, they do not respond. And majority of the patients even do not respond to PD-1 or PD-L1 inhibitors. If we talk about the 5-year survival, it is to the tune of less than 5%. So there remains a high unmet treatment need in patients with metastatic urinary bladder cancer. Also, there are limited treatment options when the patient progresses after the platinum based and after the PD-1 and PD-L1 inhibitor. So there comes the role of EV, that is enfortumab vedotin, which is indicated in the treatment of adult patients with locally advanced or metastatic bladder cancer who have already received PD-1 or PD-L1 inhibitor and a platinum-based chemotherapy in neoadjuvant, adjuvant, locally advanced or metastatic setting. So this means that EV increases the treatment options for these patients. So, talking about this study, EV301, which is enfortumab vedotin in previously treated advanced urothelial carcinoma. So, EV is indicated, as I've told, in the subset of patients who have already progressed on platinum and PD-L1 inhibitor. So, this is a treatment for these patients who have already received the multiple lines of systemic therapy. So, brief about the background. Platinum-based chemotherapy and PD-L1 inhibitors are recommended treatment options for these patients who are metastatic urothelial cancer. But overall, the patient survival is poor and unmet needs remain. So patient may be unfit for chemotherapy or others may become resistant to it. And also the duration of response and the response rate to PD-1 and PD-L1 are very, very low. So there are limited options for these patients who progress on these therapies. So this study, which is EV301, this was designed to confirm the clinical benefit of EV compared with chemotherapy in these pre-treated subset of population. So this is an international open label randomized phase 3 study. And the study design was very simple. They took 600 patients of ECOG performance status of 0 or 1 who have already progressed on prior PD-1 and PD-L1 inhibitor and prior platinum-based chemotherapy. So this 600 patients were divided into two arms, where one arm received enfortumab vedotin at the dose of 1.25 mg per kg, given as 30 minutes infusion on day 1, 8 and 15 of 28-day cycle. And this was compared with the chemotherapy, be it docetaxel, paclitaxel or vinflunine. And this trial also compared the efficacy and safety of EV as compared to chemotherapy. The primary endpoint was overall survival and secondary endpoints were PFS, overall response rate, duration of response and quality of life. So the baseline characteristics were well matched between these two groups. The median age was 68 years, majority were male from the Western Europe population. Majority had ECOG performance status of 1 and this Belmont risk score was favorable. So what was this? It comprised of three factors. One was ECOG performance status, another was hemoglobin and the third one was liver metastasis. So based on these, those patients who had 0 or 1, they were favorable and majority of them were favorable in EV301 study. And apart from these, also liver metastasis and visceral disease was also present in majority of the patients and majority had already received 1 or 2 lines of prior treatment. So these were the results. As you can see that the overall survival was 8.9 months in the chemotherapy arm as compared to 12.8 months in the EV arm. If you look at the 1 year overall survival, it was 39 versus 51% favoring the EV arm. And you can see that there is well separation of the curves between EV and chemotherapy. So being this overall survival and being this hazard ratio, it was seen that EV significantly reduced the risk of death by 30% compared with chemotherapy. And due to significant improvement in this overall survival, this EV301 study was prematurely stopped after the interim analysis with the intention to treat population. And this overall survival benefit was seen across all the subgroups, irrespective of the age. You can see that whether it was elderly, that is more than 75 years of age, this EV benefited. It was irrespective of the sex, irrespective of the performance status and the liver metastasis, and irrespective of the prior treatment lines which were given to these patients. So coming on to the PFS benefit. So PFS was 3.7 months versus 5.5 months in chemotherapy versus EV, again favoring the EV arm. And you can see that again there is well separation of these curves. So EV significantly reduced the risk of progression or death by 38% as compared to chemotherapy in the subset of population. Again, the forest plot is similar for PFS, and you can see that this PFS benefit was seen across all the subgroups, similar to what we have seen as the overall survival forest plot. Coming on to the duration of response, coming on to the overall response rate first, you can see that the overall response rate in chemotherapy arm was 18% as compared to 41% in the EV arm. So this was more than double. So it was 2.2 times higher in the EV arm as compared to the chemotherapy arm, the overall response rate. So that was again favored in the EV arm. So this confirms that we have the overall response rate, which is 2.2 times higher in the EV as compared to chemotherapy subgroup with a very, very significant p-value. Again, similar, there was higher overall response rate across all the subgroups which favored EV as compared to chemotherapy alone. Coming on to the quality of life, so you can see that there is maintained quality of life was seen as shown by this graph with chemotherapy as compared to more dips and deterioration in the chemotherapy arm, which was seen in the EV301 study. So this means that baseline quality of life was maintained with EV with more consistency as compared to chemotherapy. So EV was also associated with numerically smaller deterioration and less variability in the quality of life score as compared to chemotherapy. And talking about the quality of life, in the first 12 weeks of treatment, the overall patient reported quality of life was maintained with the EV and was more stable as compared to chemotherapy, which was the assessment was done with the EORTC global health status. And again, EV was associated with significant reduction in pain from the baseline as compared to chemotherapy at week 12. And EV improved all the functioning domains and all the symptomatic domains, including pain, fatigue, dyspnea, and constipation, which was not there in the chemotherapy arm. So this provides meaningfully improved quality of life, which was seen with the EV as compared to chemotherapy. Now, talking about the adverse events, the majority of the adverse events, they were similar in between these two groups, but the adverse events which were associated mainly with the EV arm was alopecia, neuropathy, pruritus, including the maculopapular rash, decreased appetite, and some of the GI symptoms like diarrhea and nausea. And the side effects which were more associated with the chemotherapy arm was hematological side effects, which was decrease in the blood counts. And looking at these, the side effects leading to death were similar. It was 5 and 7% respectively in chemotherapy and EV arm. This was leading to death, but if you see that the total side effects were matched between these two groups, although the side effect profile was different between these two groups. So coming on to the patients who had the dose reduction or interruption, in EV arm, 32% of the patients had dose reduction, 51% had dose interruption, and 13% of the patient had dose withdrawal. But most of the adverse events were well managed with either the dose reduction or interruption. Very low proportion of the patients required the withdrawal of treatment, that is only 13%. This is again a very busy slide which shows that the adverse events were mainly mild to moderate in severity and grade 3, grade 4 events were less than 2%. So this was very interesting facts that most of the events, they occurred in the first few months of the initiating treatment. For example, the corneal events occurred in first to 2 months, and the skin reactions occurred even with the first infusion of enfortumab vedotin. So to summarize this study, so EV significantly improved outcomes versus chemotherapy in patients who were already treated with platinum-based chemotherapy and PD-L1 inhibitor. So the median overall survival was improved from 8 to 12 months with EV with 30% lower risk of death. The PFS was improved from 3.7 to 5.5 months with EV with 37% lower risk of progression or death. The overall response rate was improved from 18 to 41%, that is 2.2 times higher response was seen with EV as compared to chemo. And there was also significant reduction in pain from baseline with EV as compared to single agent chemotherapy in this study. So to summarize this particular study, EV301 was open label randomized phase 3 study in patients who were metastatic urothelial cancer and who have already received platinum based chemotherapy and one PD-1 or PD-L1 inhibitor. In those patients, EV significantly improved the median overall survival, the median PFS, and the overall response rate. So EV is an effective treatment option in these subset of patients with overall response rate to the tune of 40 to 45% across its clinical program. So this was about the first part of my talk. Coming on to the second part, few slides on the real world evidence to support this decision making on EV. So we have this UNITE registry, which is a US based registry, which is actually the collaboration of 16 institutions. They had this study and they treated 260 patients with EV monotherapy, and they found the results which was at par or slightly better than the 301 study. So there the overall response rate was 52%, PFS was 6.8 months, and overall survival was 14.4 months, which was 12 months in the EV301 study. Also, another interesting fact was that overall response rate was higher in the pure urothelial arm as compared to the variant histology. So these were the patient subset. You can see that the pure urothelial histology had better response with the EV monotherapy as compared to variant histology. Also, this UNITE means Urothelial Cancer Network to investigate the therapeutic experiences. And this was compared, total 304 patients were taken. Out of those, 260 patients received EV. And the results I have already shown. And interesting fact was 67% of the patients already had received 2 or more prior lines of therapy. And this also showed that there was this benefit of EV was seen irrespective of the heavily pretreated patients, irrespective of the mixed histology, irrespective of the primary site, and irrespective of the TMB and PDL1, whether it was high or low, the benefit of EV was seen as compared to chemotherapy. Now, this chart shows that the certain histology variants which are actually associated with poor outcomes, such as the squamous, the micropapillary, and the sarcomatoid histology, they also showed benefit with EV as compared to chemotherapy. So there is another study which had the North American population, which showed that the benefit of EV was even seen in patients who had actually been treated with more than 3 lines of prior chemotherapy and PD-L1 inhibitors. So this was again a retrospective study from German and Swiss hospitals, which showed actually better results as compared to EV301, which showed that the adverse events were lower, which was 32%. Overall survival was almost similar, which was 46%, and PFS and OS was of 7 months and 12 months respectively was seen in this trial. And you can see that this graph, the median PFS was 7 months and the median OS was 12 months, which was at par with the 301 study, which was shown in these Germany and Switzerland study. Last, coming on to the Japanese data, which is comprising of 97 patients. Again, similar response rate was seen, which was to the tune of 43%, with similar adverse events like the grade 3 rash, peripheral neuropathy, and hyperglycemia. So this shows, so this was another interesting fact, and this was seen in the Japanese study, which showed that the patients who developed the peripheral neuropathy, they had better PFS and OS, which we usually also see with the cetuximab-like chemotherapy in the colon cancer. So this similar result was seen in this Japanese study with the enfortumab vedotin. So my last slide. So real world evidence shows that efficacy as measured by the response rate, the progression-free survival, and the overall survival, which was observed in the 301 study, is reproduced in the real world study population. We have seen the data from North America, Europe, and Asia. And toxicity as measured by the adverse events is also observed in the real world population, which is actually similar to the EV301 study. So I once again thank all the participants, and I thank everyone for patient hearing. I thank Sachin sir for giving me this opportunity, and thank you, Estelas.
Thank you, Dr. Akanksha. It was very concise, and so now this drug is also finding its space in not only relapse refractory but upfront treatment also. So there's a recent data when it combined with pembrolizumab, and so you don't need actually chemotherapy also, and the results are even superior to the upfront chemo IO. And
Yes.
so we have a very thank you, Akanksha. So we move on to do we have any questions for Dr. Akanksha?
Just
Anybody
one
raised
quick
any hands?
one comment. Thank you,
Yes,
Akansha,
Sir
for
Sajal.
the presentation. Just wanted to know, so is this drug approved or being investigated as first-line option in advanced bladder cancer?
Yes, sir. So basically now it has already been approved. So basically first we used to treat with the platinum-based chemotherapy plus PD-L1 inhibitor, but now we even have the enfortumab vedotin plus pembrolizumab in the first line setting, and it has shown actually the improvement in the progression-free and the overall survival. So this is our first go-to regimen if available and
Okay, so
affordable.
it is recommended to treat in to use in treatment naive patients, because
Yes,
what
even
data
in
what
treatment
you
naive.
what
Yes, sir.
data you have showed is for patients who have
Relapse
progressed.
refractory.
And
Yeah.
yes, sir, that those are the slides which I was asked to. But yes,
Okay,
we have data in the first line setting as well.
thank you.
But Dr. Sajal, the problem would be the cost sector, na? Because when
Yes,
combining with Pembro and also not everybody can
can
right
afford.
now
Yes.
afford those things. But gradually, this would be more acceptable and used also in clinic.
Also, sir, I think because DCGI approval is not in the first line setting, which is why the slides discussed today are only in the second
Yeah,
line setting and beyond.
that also. But I think that data is actually quite impressive.
Yes,
And of course, but do we
Yes,
do
yes,
have
sir.
toxicities of these drugs? So ADCs are not that kind and that easy to handle. But of course, in urothelial, a lot of times cisplatin cannot be given. There are so many patients who are platinum ineligible. So there it makes more sense to use these drugs.
yes, sir.
So should we move ahead? I think we are pretty much on time. Dr. Ankit is eagerly waiting to start his moderation. I welcome Dr. Ankit Agarwal. Uh, So Dr. Ankit is a dear colleague from Udaipur, and Dr. Ankit, you would invite your panelists?
Definitely, sir, I can do that.
Yeah, please go ahead.
Okay. Thank you, Sachin sir, for inviting me and having me here. I think it's a wonderful discussion that has been going on since the past 1 hour, and very interesting topics, and the agenda looks amazing. So, without wasting further time, I think it's time for our panel discussion. I would like to invite my expert panelists. Uh, um, do we have Dr. Jagdeep Singh from Amritsar?
Yes, good evening, Dr. Ankit. Good evening,
Hi.
Sachin sir.
Good evening, Dr. Anuj Bansal from Batinda.
Yes, Dr. Ankit, I'm available.
Hi, good evening, sir.
Good evening.
Dr. Nitika Joshi from Mohali.
Good evening, sir. Good evening, Sachin sir.
Hi, good evening. Dr. Prabhat from Chandigarh.
Hi, good evening.
Good evening. And Dr. Kanupriya from Ludhiana.
Yes, hi, sir. Good
We
evening.
got a full house, right?
Perfect, sir. Perfect. I think it's going to be
Yeah.
an amazing discussion. Let me share my slides, and so that we can kickstart and roll off for our next discussion. Okay. Okay. So I think we have answers to Dr. Kakkar sir. I think so. We'll discuss about the first line treatment for metastatic bladder cancer. And are my slides visible? I'll just make it full screen. Are my slides visible? Can we start
Yes.
the discussion, Sachin sir? Can we
Yes,
start?
Dr. Ankit, please.
All right. Okay. Perfect. All right. So I think similar to other solid organs, especially in GI and lung, I think one of the most recent advances and the practice-changing guidelines that have happened is in the urinary bladder malignancy. The armamentarium of treatment and the availability of options that we have has dramatically changed from chemotherapy to immuno and now ADC in the first line setting. I think it has been Dr. Kansha has beautifully described the role of enfortumab vedotin in the relapse refractory setting. Nevertheless, it has also been approved, FDA approved in first line metastatic, and after first line metastatic, I think it has also come up in the perioperative setting. So gradually ADC has come up in the first line as well as in M0 setting in metastatic bladder cancer. So what we are here is we are going to discuss about the role of immunotherapy and antibody drug conjugates in metastatic bladder cancer. We'll restrict our discussion to M1 setting. We'll try to discuss about the second line options also if the time permits. So our primary focus will be on the first line management of urinary bladder cancer. Now, for a point of discussion, I think we'll keep aside the cost issue. I think we'll discuss about the best available option that we have if the cost is not an issue for our patients. So here we'll start with a case discussion. Here we have a 74-year-old male, ex-army person, ex-smoker, no comorbidities, PS performance status 1, evaluated for painless hematuria. Imaging and biopsy showed high-grade invasive urothelial carcinoma with mediastinal and multiple lung mets. Patient's creatinine clearance is 75 with an ejection fraction of 66%. So we have a metastatic bladder cancer of 74 years age who has a good creatinine clearance and a performance status of 1. So coming to the options that we have currently as first line setting, we'll start with Dr. Jagdeep Singh sir. So how do you go about treating this patient? How do you feel about the available options that we have? We'll keep the cost aside. We'll discuss about the treatment plan that we most commonly use in our clinical scenario, as well as the available first line options that you would like to use if your patient does not have cost constraints. Dr. Jagdeep sir, can you please highlight on that?
Dr. Ankit, one thing I would like to update. So we got the DGCA approval for the first line for enfortumab vedotin plus pembro. So that approval is right now. We have it with us. So
All right.
this is the first line drug which is approved. We can get the assistance because of course the cost is not an issue right now when we are discussing.
Yeah.
So if you go with the GemCess plus Evolum maintenance or GemCess plus Nivo, So if you see, I cannot compare the trial with the other trials, but if you see the PFS, even in the maintenance with the avelumab is not so much what we have achieved with the EV plus pembro. So
Exactly.
given these options, I'll go with the EV plus pembro as a first line option in this patient.
Perfect. Agree, sir. Agree. Dr. Anuj Bansal, can we have your opinion, please? How do you
Yes,
see
I
about?
think as per the EV302 trial, Keynote 091 trial, this is a standard at present and best overall response rate, best PFS and OS. So my first go will be EV plus Pembro, but in practice, definitely we give Gemsys plus IO.
I think routinely either GEMSs alone if the patient is not affordable, or a combination of GEMSs with IO, either a switch maintenance or continuous maintenance with nivolumab if we feel. I think that is where we usually use. If cost is not an issue, then I think we are all very much inclined to use enfortumab vedotin with pembrolizumab. Here we have the enfortumab vedotin trial along with pembrolizumab. It is the EV302 study design. So basically, untreated metastatic urinary bladder cancers who were eligible for platinum chemotherapy, either they were randomized into two arms. They received either enfortumab vedotin with pembro versus platinum-based chemotherapy. The platinum and the primary endpoints what they looked at was progression-free survival and overall survival. There were pre-specified secondary endpoints which they looked at was the overall response rates by BICR. So basically, a very interesting data has come up after this EV302 trial. As you can see, a significant improvement of progression-free survival was seen when EV pembro was compared to the chemo arm. The hazard ratio of 0.45, a 55% reduction in the risk of progression, and a doubling of the median PFS, 6.3 versus 12.5 months. I think the difference in PFS has been huge. Similarly, the difference in the overall survival, as you can see, almost doubling of the overall survival was seen when the EV pembro was compared to chemotherapy. The median OS was 16 months versus 31 months when EV was given to the patients. A hazard ratio of 0.47, 53% reduction in the risk of death. I think this is one data which has definitely has to be the most impressive data which we have seen till now in bladder cancer in the first line setting. And that is why probably I think Dr. Jagdeep and Dr. Anuj Bansal are absolutely right. I think if we get a chance, definitely we would love to use EV and pembro in a first line setting in our patients. As you can see in the data of EV302 trial, it also showed that even in the subgroup analysis, if the patient was cisplatin eligible or ineligible, the benefit of EV plus pembro was passed on to both the subgroup of the patients. So it does not matter if your patient is cisplatin eligible or not. EV plus pembro has a significant advantage in progression-free survival for patients. Even if the patient's CPS score is more than 10 or less than 10, irrespective of the CPS score, the benefit of the drug combination was passed on to this subgroup of population. So basically, you don't have to get a PDL1 testing done. If you are planning for pembro plus EV, you don't have to see whether your patient is cisplatin eligible or not. It's just that if your patient does not have any contraindication of immunotherapy, does not have any contraindication of EV, I think it's the first choice as we see the data of EV302 trial. Now, coming to our second option of first line, Dr. Nitika Joshi, can we have some highlight on how do you see the data of GEMSIS with avelumab maintenance? I think we have a good data of the Javelin Bladder 100 trial. Dr. Nitika, can we have your opinion on the trial and the results, please?
Good evening, sir. Sir, in my practice, we are mostly using nivolumab, but have used avelumab in 3 to 4 patients and have seen good results with avelumab also. One patient is in near CR and one is mostly show partial response and stable disease. So both are doing good. If cost is the issue, then if patient cannot afford for EV and pembro, then nivolumab or avelumab is also a good option with the cisplatin and gemcitabine based chemotherapy. So this is also these are actually my go-to options because most patients can't afford EV and Pembro.
Okay, so Dr. Nitika, just a point that I want to discuss about the Evolumab trial is the subgroup analysis that they did. So this is this is the overall survival and the progression-free survival data. A significant advantage in the overall survival, as you can see, the p-value is significant. Overall survival was 23.8 months in the Evolumab trial versus best supportive care. So what they did basically was they gave Evolumab to only those patients who had either a stable
Good
disease,
response,
yeah,
yes,
either
sir.
a good
After
response.
platinum based.
So it was basically kind of a switch maintenance that they wanted, that they used. Now, a subgroup analysis that came out of this data was only those patients, or I would say those patients who had a complete response to chemotherapy, 4 cycles or 6 cycles, they were the patients who had the best response later with Evolumab. As you can see the data, those patients who had a complete response with chemo, they continued to show a very good response with Evolumab also. Those patients who had a partial response or stable disease, they had a relatively lesser response to Evolumab, and or they, I would say, they relapsed earlier. So are you inclined to use Evolumab only for those patients who have complete response, or you use it for every patient who has a response to chemo?
Sir, for even if disease is stable, we are using Evolumab maintenance,
I
not
think the
for only those.
yeah, I think the data, the guidelines say that you should use it for everyone, but I think this is one point to ponder on. Probably those patients who had a complete response, they responded very well even to Evolumab. I think if we look at the data, we definitely use Evolumab for every patient who has responded to GemCis. But if we go into the details of this trial, or if we have another trial wherein we see who are the actual patients who responded, who had the benefit of Evolumab, I think that is where we can find out who are the patients who should be given Evolumab and who are the patients who can skip Evolumab with even if they have a good response. I agree with Dr. Nitika that currently we are using it for everyone. Dr. Prabhat, coming to the third first line option that we have, the Checkmate 901. Dr. Nitika is more fond of nivolumab. She's routinely using nivolumab in her clinical practice. How do you go about your clinical practice regarding the Checkmate 901 trial?
I think the selection comes down to the partner chemotherapy that we're using, so carbo or cisplatin, that will decide one of our options.
Absolutely.
I'm actually more inclined to use avelumab maintenance if the patient can afford it, because obviously you can kind of select the patients who don't progress on therapy, and I would give it to probably all patients who are not progressing, because it's a better maintenance strategy than giving gemcitabine maintenance or giving nothing, because there will be a small population who will respond, who will have at least a longer PFS with that. So, considering that, I would use switch maintenance. With nivolumab, definitely with the biosimilar coming in, this is a good option for patients who could not afford it earlier. Um, I would say, yeah, I think if we are using cisplatin, both the options are doable. It's based on the affordability of patients. If they can afford nivolumab from the beginning, then yeah.
I think it's just a matter of experience, and I think both the trials stand their own. They have their own good data, and it's just it's just our experience. Where do we use? And I think I agree, totally agree. If you're planning to use cisplatin, I think you have both the options. But if you have carboplatin in your picture, I think then Checkmate 901 takes a backstage. I think then avelumab is where you want to go for if your patient is cisplatin ineligible. We don't have the data if the patient is given nivolumab with gemcarbo. We don't know what will be the results. The only thing that I wanted to ask Dr. Prabhat is uh, the median OS has not been, the difference in median OS has not been huge. 18.9 months, 21.7 months. Even if we talk about the median PFS, the difference has been only 0.3 months. So I think this is what we usually expect, that immuno does not produces a huge difference in median PFS. It's because of its slow onset of action. Your comment on this, please.
I would say one contributing factor to this is that they have not selected the population who are responding to chemotherapy. If we are giving it in an unselected population, we will have that initial drop off who don't really benefit with immunotherapy. And so I think there is no, I mean that the benefit is marginal here. But yeah, otherwise, I mean, as a general option, it's still it's viable. It is showing a statistically significant difference, and we cannot compare cross trial.
Yeah.
But this is one of the reasons why I would prefer avelumab maintenance.
Okay. So, all right, all right. I have one more question on avelumab. I'll ask that question to our fifth panelist, Dr. Kanupriya. Do we have
Yes,
you
yes,
with
I'm
us?
here.
Hi. Okay, so coming to the javelin bladder trial again, I think a very strange trial for me. When they gave avelumab maintenance in one arm, they did not give anything in the other arm. It was only best supportive care.
Yeah.
So how do you see about this? Nothing in the other arm. Probably they should have given gemcitabine single agent or something like that. What
Sir,
do you?
at that time, I think the standard of care was this. We just gave few cycles of chemotherapy and then we put the patient on observation. So at that time, that was the standard of care. So we particularly, I don't think we can criticize the trial on that. It is difficult to give gemcitabine for a very long period of time to patients. We've seen that in biliary tract cancers also. So I believe that is one thing.
So currently, if your patient has received 6 cycles gem carbo,
Yes.
responded to 6 cycles gem carbo, you just stop the treatment. Is it? Do we do like that usually
Yes, sir. I don't continue after 6 to 8 cycles. No,
in
sir.
in M1 disease, even in metastatic setting?
Yes, sir. No, I don't continue.
All right, all right, okay. I think it's a uh, personal choice. I think
Same
I'll not.
thing with me as well.
Sorry.
I also don't give gemcitabine maintenance.
Right.
For me, my practice, I give 6 cycles of gem cis or gem carb, and then follow up.
And then observation.
Yes.
Okay, and okay, all right, all right. I think we have consensus with the among the panelists. Okay, so coming to the checkmate 901, I think we have discussed about the checkmate 901. A good response rate. We have both the options. I think first option is definitely we see that enfortumab vedotin with pembro is the number one regimen to be used. In case if affordability is an issue, I think immuno with chemo is an option, and if at all immuno is also not a possibility, then GemCis is an option if the patient is cisplatin eligible. I think this is the definition of cisplatin ineligibility. We do use it routinely in our clinical practice. Any addition, anything you want to add? Any of our panelists would like to comment on this definition of cisplatin ineligibility? Do you have anything that you want to add, or we follow this same routine clinical practice?
So, Dr. Ankit, usually, honestly, I don't do this audiometry. I go with the just creatinine clearance in my day-to-day practice. And coming to this peripheral neuropathy, usually by the time the patient who are in 74 years, so they have some comorbidity of diabetes or something, some sort of peripheral neuropathy with either grade 1 or 2 will be there in those people. I suppose I anticipate these things.
Yeah, yeah.
I think this with creatinine clearance, what we do in a routine practice is a better way to go ahead rather than doing other things to check for any cisplatin ineligibility in our practice.
Okay, okay, agree. All right, all right. Okay, so on routine clinical practice, there are some definitely performance status is the first thing that we look at, and the creatinine clearance. These are the minimum basic thing that we look at to decide on whether the patient is cisplatin eligible or not. So,
I would also add that creatinine clearance of 60 cannot be taken as the lower limit for cisplatin eligibility, especially if we are using a split dosing.
I agree. I think now recent data has been coming up that probably a less than 50 creatinine clearance, or even some trials are saying less than 40 patient can be considered as cisplatin eligible. All right, all right. I agree. Totally agree.
Cardiac dysfunction, I think that is very important because
Yes,
Yes,
yes.
cardiac dysfunction is very important,
Yeah.
often overlooked.
How frequently are we getting a echocardiography done before we decide on cisplatin eligibility?
For elderly patient, most of the patient we do.
Not for less than 50 years.
Yes, not for less than 50
Yes,
years.
I think I agree. Most of us are doing the same. Most of us are practicing the same. Less than 50, if the patient does not have symptoms, we are not routinely getting an echo done. But elderly, we are routinely going for an echocardiography to have the cardiac function assessed. I think we'll not go into the M0 disease. If we have time, we'll come back to the M0 disease. Okay. Now, the similar patient, if this patient was cisplatin ineligible, a creatinine clearance of 35 ml per minute, metastatic disease, upfront treatment regimen. We'll start with Dr. Kanopriya now. Dr. Kanopriya, your choice of treatment. Affordability is not an issue. We'll again start with the patient who does not have any issue with the affordability. Creatinine clearance 35 ml. Enfortumab vedotin plus pembro is an option. What if enfortumab vedotin plus pembro is not an option? What is your next go-to treatment for
Sir, I
you?
would also want to know the performance status of the patient. Like you said, EV Pembro is an option, though it will be very difficult to give EV Pembro also in this patient with the
Okay,
side effects of hyperglycemia and neuropathy that are going to happen.
agreed.
And if I say that the performance status is good and with these comorbidities, I think a combination of gemcitabine and carboplatin can be tried. Otherwise, I will want to test PDL1 if the performance status is not good and maybe go for single monotherapy, monoimmunotherapy.
Okay, if the PDL1, Dr. Prabhat, how do you go about this? PDL1, 30%.
I would not decide on the basis of PDL1.
Okay.
Here, the thing that worries me about using EV is again the hyperglycemia risk and neuropathy worsening. If the neuropathy is not very severe and sugars are well controlled, I would still want to use EV Pembro. If not EV Pembro, then I think carboplatin is still an option. Creat clearance 35. I think we can still use gem carbo. Um, if the patient is not eligible for any sort of platinum, then I think single agent pembrolizumab would be the option.
So, Pembro
Please,
versus Gem. Oh,
sir,
sorry. Yes, ma'am, please.
sir, please conclude the session.
Just 2 minutes. Okay, Dr. Nitika, your take on the treatment plan. Pembro versus
Sir,
Gem. You have two options. You have Pembro, you have Gem Carbo. What do you want to prefer?
sir, in this patient, Pembro.
Dr. Anuj, your opinion. Dr. Jagdeep, please pitch in.
For me, I think Pembro or Gemca. Gemca maybe for all patients I can
So
try.
From my side, I'll go with the single agent pembrolizumab in this patient who is cisplatin ineligible. That will be my take for this patient.
Actually, I think Gemcarbo plus Pembro. I think both the options. We do have both the options with us. Pembro, we don't have a direct head-on trial of Pembro versus Gemcarbo, but I think Pembro also stands a good chance that it can be used in the first-line setting for those patients who are cisplatin eligible. We have phase 2 trials suggesting that the median OS has been close to 1 year with single agent Pembro and close to 16 months with single agent atezolizumab. So I think both the options stand correct with either Pembro or atezoli or Gemcarbo. But the only thing that I wanted to highlight was those patients who had a CPS score of more than 10, they had a good response rates with Pembro and atezolizumab with a good OS. So probably I think keeping PDL1 in mind, we can use Pembro or atezolizumab for our patients who are cisplatin ineligible M1 disease in the first line setting. I think PDL1 routinely we are not using for first line only if the patient is not eligible for cisplatin. It is an indication that probably Pembro or atezolizumab can be given. I think okay, so I don't think we have much time to discuss about this thing. We'll just summarize. So cisplatin eligible, I think enfortumab vedotin plus Pembro is the first choice of option if the patient is cisplatin ineligible. PDL1 testing. If PDL1 is high, immunotherapy can be considered. Gemcarbo still holds a good chance. We have been routinely using Gemcarbo and we're getting a fair amount of response and survival with Gemcarbo. Patient has in the second line we have a number of drugs. If the patient has not been exposed to immunotherapy also stands a good hold in the second line setting. Enfortumab vedotin, second line, third line, we have options of enfortumab vedotin, and I think the FGFR3 inhibitor, erdafitinib, also comes into picture in the third line or second line, depending on when immuno has been used. I thank all my panelists I think we'll end up here, and back to Sachin sir and the organizers. Thank you.
Thank you, Dr. Ankit. That was a very exciting panel discussion, and you summarized it so well. Thank you, all the panelists.
Thanks.
And I think we are little now delayed the time, so we have to hurry up with things. So our next talk is by Dr. Sandeep Cooper. He's a good friend. He's Director Medical Oncology at Park Hospital in Mohali. And so he'll be delivering a lecture on optimizing first-line treatment strategies in advanced RCC, evidence-based IO and IO-TKI combinations. So this is a BMS-sponsored session. Dr. Sandeep, stage is yours. You
Good
can share
evening,
your
sir.
slides.
Thank you
Yeah.
for the invite. I hope I am audible
Yes, sir, you're audible.
and the slides are moving.
Tech team,
Please make it
stop.
full screen.
I have made it full screen.
Yes, sir.
The slides are moving.
Not yet.
No, sir.
They are not moving.
लेफ्ट हैंड
उसको
साइड
स्लाइड शेयर स्लाइड वो
पॉपअप
किया
है उसको क्लोज कर दीजिए सर
सर फुल स्क्रीन नहीं है
यार, मुझे तो फुल स्क्रीन ही दिख रहा है. Anyway,
टेक टीम रिकॉर्डिंग भी ऑफ कर दीजिए
now is it still not full screen?
Tech team, please stop the recording. Tech support.
यस मैम
Just a moment.
Horizon team, you can share from your side.
हाँ सर मैं यही बोलने वाली थी.
Will
Shall we
that be
Just a moment.
share?
Sir. Give me a moment. एक मिनट दीजिए बस.
all right?
Now is it okay? And is it full screen now?
No sir, it is not full screen.
slide show कर दो ना, right hand lower side slide show click करो फिर आएगा.
सर स्लाइड शो भी कर दिया मेरे लैपटॉप पे. चलो एनीवेज आई थिंक आप लोगों को शेयर कर आप लोग शेयर करेंगे तो दैट विल बी बेटर क्योंकि
सर आप स्टॉप शेयर कर दीजिए.
जस्ट मोमेंट.
Accepting our invite, and you can invite your panelists now. Dr. Rajat, you are muted.
Sir, you are not audible.
Dr. Rajat, are you there?
He is there.
Yeah, he's there. Yes. You can start sharing your screen. Maybe I'll invite your panelists meanwhile, huh? So Dr. Mukesh Bansal from Chandigarh, Dr. Kanika Sharma, Dr. Deepa Singla, all from Tri-City. They are senior medical oncologists here, and Dr. Deepak Bharti is from Jammu. So everybody is here. You can.
Can somebody please confirm if am I audible?
Yes.
Okay, right. Sir, good evening. So, can I start now?
Yes, go ahead, please.
Right. So, I thank Dr. Sachin Gupta for having me here, and I thank him doubly for giving me a panel which is not sponsored, because I have been listening to this talk by Dr. Gupkar, and he did a wonderful job telling us about nivolumab, its combination with ipi, its combination with cabozantinib in metastatic RCC. As you very rightly said, sir, there are so many
Dr.
other
Rajat, sir, can you hear
options
us?
which are.
Hello?
Hello.
Yes, sir, we can hear you.
Is it audible?
Yes, you are audible.
Yeah. Yeah. So so there are so many other options which are available.
Sir, please share your slides.
Can somebody share the slides, please?
Yes, I can share.
Pooja, can you connect Dr. Rajat, sir? I think Dr. Rajat, we can see he's there.
Am I audible?
Very much, sir. Now you're absolutely
Yeah.
audible, and
Yeah.
all your esteemed panelists are with you. Over to you, sir. So, Pooja, keep sharing the slides one by one as Dr. Rajat will guide. Over to you, sir.
Right. Thank you once again. So I think I was in a low network. Now the network is better. So like I was saying that there are so many other options that we have apart from nivolumab based combinations, which of course are very good options, I would say. And the previous speaker, Dr. Kukad, was talking about the same. So since this is a non-sponsored panel, I think all my panelists who are my esteemed colleagues from Chandigarh and Jammu would be able to give us a better insight of as to how do they really go about treating their patients of metastatic renal cell carcinoma. So we have with us Dr. Mukesh Bansal, Dr. Kanika Sharma, and Dr. Deepak Singla from Chandigarh. Welcome all of you, and Dr. Deepak Bharti, my good friend from Jammu. So as we start now, my first go-to question in all the RCC patients is that are we really stratifying all our patients according to IMDC as of now? Dr. Deepak Bharti, I would start with you. Dr. Deepak, please tell me, do you stratify all your patients according to IMDC?
Yeah, definitely. So good evening, everyone, and especially Dr. Rajat. So definitely, when a patient comes to, we always use the routine parameter, and especially we do the LDH and calcium so that we can fit in the IMDC, and definitely we segregate the patients as per the low, intermediate, and high risk accordingly. And definitely some part to play, and we can tell the patient the prognosis expert also, and especially the median survival is based on that also. So whenever we plan the patient, we start with the IMDC from day one, and definitely we follow this on surveillance or on the subsequent setting also, and later on it will give us the idea because a lot of patients come to us and will ask us regarding the survival. So this thing will tell us that in the literature that what we are dealing up to and what we have to tell the patients, and definitely one way or other way we have to do the IMDC, and we are following, and I hope everyone is following the same pan India and worldwide.
So you are on mute.
Sorry. Deepak Singla, I was ask you IMDC for every.
Sorry, Rajat, can you repeat it, please? What is your question?
I'm saying IMDC stratification, risk stratification, all
Yes.
patients.
Yes, most of the patient we are doing it. I mean, for the risk and prognostic stratification, and all the routine testing, including serum calcium and LDH, we are doing it. So, although
Okay.
treatment may be remain the same, but definitely it
Okay,
has
Dr.
prognostic value.
Yeah, we'll come to that. We'll come to that. Dr. Kanika, risk stratification for everybody.
Yes, sir, but it is not the ultimate deciding factor for the therapy. Maybe just to have the idea, it's like how aggressive and how shorter duration of the disease presentation is. But again, it depends on the PS, what is the disease burden of the patient. So all these factors depend on obviously what is the financial status of the patient. But yes, we do risk stratification in all the patients.
Okay. So, Dr. Mukesh, if we have to ask you, what all are considered factors for you in your patients who come to you with metastatic RCC to decide about the first line treatment of such patients?
Sir, actually, you are not very much audible. If I have understood your question, you want to ask me what are the factors which I consider before starting the treatment for the patient, Dr. Rajat?
Yes.
Yes, yes, yes.
Yeah, yeah. So I think like Dr. Kani of the patient, the disease volume of the patient, any major visceral organ involved, and the symptomatic status of the patient, and then financial status of the patient, that is important. This IMDC risk factor is also important, although not the only thing. I am not doing it exactly in every patient, because most of the time treatment options, irrespective of whether it is poor or intermediate risk or good risk, remain same, and almost nowadays similar options are there. These are the four five, and the comorbidity status of the patient. These are the four five things I consider before starting the treatment.
Okay. So between the IO versus IO TKI combination, which is the one that you prefer, and any particular reason for the same?
Sir, it totally depends on the patient. IO combination, I will like to start in a patient who has a, good performance status, low disease volume. Patient is not very much symptomatic, because the side effect profile is considerable, and the response rates, if we see, are only 42 to 45%, although there are durable responses. But when I need a faster response rate, the patient is symptomatic, then I go for IO plus TKI combination.
No. Correct.
Again, sir, you are on mute.
Rajat, you are muted.
Sorry. So Dr. Deepak Bharti,
Yes, yes.
I'm asking that between a IO plus IO versus an IO plus TKI combination, which is your go-to regimen, and any particular reason for the same in your experience, which is the most preferred regimen in your practice? I
Okay.
think points spoken
So
to you
your
by Dr. Mukesh Bansal, they are actually apt, but then just your experience.
no, there are two things. As per literature, we follow the science that high risk Nivo-IP is the drug to go at that point of time. But in my routine practice, I'm going with the IO plus TKI, whatever constitution it will be. My drug is combination is Nivo plus Cavo. And if someone has a sarcomatid variant that to more than 50%, 30%, that is the only one that I go with the IO plus IO. Otherwise, in high risk, optionally, otherwise my drug is Nivo plus Cavo, whatever intermediate or high risk patient come to me. If someone is sarcomatid variant, that to a good percentage of more than 50%, that where I tend to use IO plus IO.
Okay. So Dr. Deepak Singla, IO plus versus IO plus TKI, what is your experience, general, your go-to preferred regimen?
See, my experience with IO plus IO is not good. I have used in one patient, so he did not, responded well and ended up in the hepatotoxicity. So in majority of my patients, I use IO plus TKI. Cabo plus Nivo is my go-to regimen in the majority of the patient, or maybe Pembro as well. So, so definitely for the sarcomatid, I mean histopathology variant, we can go for a IU plus IO, but in general, majority of my patients, I give IU plus TKI.
Okay. Dr. Mukesh Bansal, you already said between the how you choose, I think. Okay, Dr. Kanika.
So same. If the patient is having too much toxicity with the TKI, then maybe
No,
I'll.
no. So the patient is a de novo metastatic case has come to you. Performance status of 0 to 1. What is your general go-to regimen? So to summarize, Dr. Mukesh said that he can choose IO and IO or IO TKI depending on the tumor burden. Dr. Deepak Bharti and Dr. Deepak Singla say that they err more on the side of IO plus TKI. What is your general experience with IO plus TKIs or IO plus IO, and what is your go-to regimen?
So it is IU plus TKI. I usually go with. Both can be done Nivo, Cabo, or Pembrol and Vatinib.
Okay. So suppose you have a 40-year-old IT professional PS0 coming to you with a metastatic RCC where there is a large right kidney mass. There are a couple of bony metastases, and there are about 5 or 6 lung nodules that one can see. And the lung nodule has been biopsied, and it is a positive for RCC. CD10 is positive. So, in such a case, what would you prefer, a dual IO or a IO plus TKI? And any particular reason for any one regimen that you may choose, Dr. Kanika?
So IO plus TKI, and initially, if we, as a most of my patients, they have toxicity with the TKI. It's not like they don't have, but since it's a 40-year-old and a working patient, so we want to maintain the quality of life of that patient. So
So which
usually
IO
we
plus
start,
TKI would you use?
so more experience, or if no cost constraint, then Pembro plus Lenvatinib.
Okay.
Otherwise, Nico plus Cabo also. Both the regimens can be used.
So more preferred is Pembro plus Lenvatinib. Clear study.
Yeah.
The dose of any particular reason for using Pembro plus Lenvatinib?
No particular reason, sir. I think the personal experience and the responses with Pembro that I get in the patient with RCC and
But you have
long
Pembro plus
terms with them.
Axitinib also. You have the keynote 426 study as well.
Yes, sir. Many combinations. Many of them, they are interchangeable also. And if the patient have some side effect with Lenvatinib, then shifted on Axitinib and Cabozantinib as well. But any of the can be used. My personal preference is Pembro plus Lenvatinib, and based on
What
the
is the
tolerance
dose of
can be shifted to other.
dose of Lenvatinib?
Okay. I just want to make the thing to the points
Yeah.
here. Regarding the TKI, I think among all the TKI, like Cabo, Paxi, and Len, Cabo is the more potent. Number one, even single agent of Cabo is good enough for that thing. Lenva with clear trial with doses of 24, I don't find anybody can use. I think we are using underdose on that, and I'm not used to that drug with Pembro. And Pembro plus Axi is a little bit less potent. I think that's the negative point of with Pembro at that point in time. I think Nivo Cabo is a winner regarding combination point, and you combine the Cabo efficacy and potency. And regarding Lenvatinib, if you use a clear trial dose, I don't find nobody can use that much dose of 24 mg, even in
Okay.
that experiment.
Okay.
That are two things.
I will come to you on specific few points, but just the case that I discussed, a 40-year-old man with some lung metastasis, some bony metastasis. So your go-to drug will be IO TKI or a dual IO, Dr. Deepak Bharti.
So there are two things. The high burden of disease.
No, for
with
this
good PSF.
patient, just one line answer, IO TKI.
I am comfortable with IOTK. That Nivo Cabo. I am not
Perfect. I'll come back to you. Dr. Deepak Singla, this patient, IO TKI or dual IO?
Yes, I mean, I will go for IO TKI with such youngster and with the heavy burden of the disease. My preferred regimen will be IO plus TKI.
Dr. Mukesh Bansal.
Sir, in this particular patient, my preference will be IO plus TKI.
Okay, so what is the reason why would you not use a dual IO in this patient? Is this your experience or your preferred choice, or is there any particular reason for it?
I think the case you described has a high tumor volume as a young IT professional with
So I said
symptomatic lung.
two bony metastases, PS0, and 4 to 5 small centimetric lung nodules, one of which has been biopsied and it is positive. So it's a low volume disease.
Okay, sorry, my bad. I got it wrong. So I think then we can use IO plus IO also in this patient.
Okay, so
Although
I like the dichotomy between the panelists which I wanted to create. So I'll come back to you. I go back to Dr. Deepak Singla. Dr. Deepak Singla, low volume. So IO or IO TKI?
My still, go-to regimen
IO
will be
TKI.
IO plus TKI.
Perfect. So I just want to make you remember that we have done 3 such panels before that also, and I could not change your IOTKI. You still stuck to IOTKI always. So still that's what you're doing. Okay, that's fine. Dr. Deepak Bharti, low volume disease.
Yes.
Still IOTKI.
Basically,
You are
I'm done with
smiling.
Yes, I'm for last 5 I'm very comfortable with IO plus TKI. I don't want to take any kind of risk with using
Any
of
kind of
EP.
risk. So you think that
No.
dual IO
And plus,
is a
Rajat, one more thing, and plus, I mean, some zoledronic or a bone modifying agent also.
We'll do that.
No,
We'll do
not
that
that.
certainly.
Absolutely.
So Dr. Deepak Bharti says that I don't
Yes.
want to create a potential toxicity to my quality of life and patient's quality of life. So
Yes.
IO
Yes.
plus TKI. So see, all the out of the four, three panelists believe IO plus TKI. One panelist says dual IO, and that too when I wanted him to speak on that, Dr. Mukesh Bansal. So in this patient where we want maximum overall survival, I think all of us will agree maximum overall survival. So a maximum overall survival, if we are going to look at with a low volume burden disease, we all understand and agree that this kind of a patient is not a regular scenario in our practice. Very less percentage of such patients would come to us. Mostly Indian patients would have huge bulk of disease, would be symptomatic when they present, symptomatic because of the primary, symptomatic because of the metastatic lesions. So if at all such a scenario which I presented comes to us where we are looking at the maximum overall survival, I think all of us agree that the tail of the curve is something that we are looking at when we are giving immunotherapy. So a dual immunotherapy has got the flattest tail of the curve. 22% patients at 7 years surviving, and also maximum overall survival that we have, and also the follow-up period is the maximum. So this is a subset where a dual IO combination can be used. Of course, IO plus TKI is not wrong. Nobody really asked me as to what is the IMDC risk stratification, because one has to understand that a dual IO combination is not for good risk at all. So if the patient is intermediate or poor risk, only then it is a dual IO. So let us believe that this patient was a IMDC score of 1, which is intermediate risk, because very importantly, a dual IO combination is not for good risk. In good risk, it was actually detrimental. So intermediate and high risk, a dual IO combination is one of the options. IO-TKI. IO-TKI is not a bad option, but one has to understand that TKI has got its own side effects. Dual IO also would have certain side effects. Dr. Deepak Singla looks quite astonished. So Dr. Deepak Singla, you used it in one patient, you said dual IO, and that patient didn't do very well, or was it because of the toxicity that you had to shift? So what was your experience with Nivo-IP? You're muted. You're muted.
Rajat, I mean, I first of all, I used very cautiously, and but the that patient didn't do well. I mean, he ended up in, first of all, infusion related toxicity. Later, he developed the hepatotoxicity, so I lost that patient. So I mean, I'm a little bit skeptical using that IO combination,
So if we see
especially
if we see from
I
if we
don't
see
want
from
to
other
scare the
side,
patient. I don't want to scare the patient in first go. I mean, with the
no. So Dr. Rajat,
any
so so
Okay.
Dr. Rajat, after giving some few points, I just want to invite that you are about to telling us, and I think you are quite legible on that. IO plus IO in young fit patients with EP of 2 or 3 doses or something like that, according to Nivo. We can keep Cabo for later on settings, and obviously with side effects of Cabo or TKI is not so low. We are seeing routinely also, and it is quite legible in young fit patient IO preparation that IO can be used, and I think we should also the meetings on like this we can change our thinking pattern also and change our what we use to routine in our OPD practice. I think IO plus IO can be given in this aspect of this patient.
So
Yes.
have I been successful in changing your plan to a
Yes.
dual IO?
Yes.
Okay,
Yes.
okay. So that is what I wanted, at least for one. Dr. Deepak Singla, I will not be able to change because I have been trying for three panel discussions. Not possible. So it's fine. I know that he is IO plus TKI. Dr. Kanika Sharma possibly may change or may not. Dr. Kanika, what do you think? So do you think that the IO TKI or dual IO? So a low volume disease, a young boy, young male, where we are wanting that this patient should live the longest, and of course, quality of life issues are there with TKI also. Dr. Ketan Dang also is there. I would come to him. I don't know if he's in the panel or not, but if he is there, I have to ask him. So, Dr. Kanika, so in these patients, don't you think that these are the only subset of patients where we should be using a dual IO? Of course, the experience of it, the toxicity is something that we can discuss. So, not all patients would have their, toxicities with the P. And of course, this is 1 milligram per kg here. But then, do you think that these are the only subset where we can possibly use the dual IO combination?
So definitely, I'm not totally against of using a dual IO in these patients, and I have used the combination, and the toxicity again is manageable. It's just when you just ask and when you are treating the patient, the more responses that you have seen with a combination or a regimen, you are more inclined to use it firsthand. So that is the only reason it. But I said it earlier also that it may depend on the patient. The whole performance status and what is the age and the background of the patient and how well he's tolerating the therapy and the responses. So again, a dual IU is one of the treatment options that can be discussed with the patient and
Okay.
then can be planned accordingly.
Okay, so I come to Dr. Ketan Dang. Dr. Ketan, hi. So, hands on your heart, at IO plus TKI that you've used, one, have you used a full dose of a Pembro plus Lenva, for example, or even a Nivo plus Cabo? So, Dr. Deepak Bharti said that Nivo plus Cabo is a hands-on winner. So, BMS and Zydus will be very happy to see that Nivo plus Cabo is a hands-on winner. But then, have you used a full dose of Cabo in Nivo Cabo and full dose of Lenva in Pembro plus Lenva 1? And number two is that whatever dose we may be using, do most of our patients have that toxicity of a hand-foot syndrome or a hypertension or a mucositis where we have to always pick their calls, tell them to reduce the dose, maybe a 5-on-7 strategy and everything. So can we say that even a IO plus TKI combination is not the best quality of life that we are giving to our patients? What is your experience, Dr. Ketan?
Sir, sorry
Good
to
evening,
interrupt you.
everybody.
Yes, please. I
Yeah,
think from the please,
yeah.
please.
First of all, I would like to mention a disclaimer that I have just popped in, so I was not aware of what has been discussed earlier. But jumping straight to the question that you asked, fortunately, I have had the experience of using, like you all colleagues, dear colleagues, I have had the experience of using them. And in my experience, definitely cabozantinib combined with Nivo is a big thumbs up. But I have don't remember any patient tolerating the full dose of cabozantinib. Almost always necessitating a dose reduction in the 1 to 3 months of introduction. That is for sure that I have noted over these years. And regarding Pembro and Lenva, I would say Lenva is also fairly well tolerated, but not in the full dose. The maximum that I have been able to continue my patients on for a few months is 16 mg when I have combined it with pembrolizumab. And I would say that having used Nevo plus Ipi combo left, right, and center, we are not that scared of the toxicity, especially when the patient has absolutely no contraindication, including no controlled autoimmune disease, and they can frequently visit the hospital. And age below 70, I would say, has been my practice to use Nevo Epi lavishly, that subset.
Okay. I think so. Very eloquently put. I
Excuse
think the
me, sir.
organizers. Yes, please, please.
Sir, please conclude the session.
Yes. The organizers want us to stop. So, just a couple of minutes. So, I think one thing is very clear that IO-TKI is the preferred regimen because IO plus IO combination possibly, people have that there would be some adverse effects of ipilimumab, possibly some quality of life issues, maybe some mortalities also that some of the trials have seen. Although we've learned over a period of time how to really deal with the dual IO and their toxicities. Anybody for a triplet? Dr. Deepak Singla triplet. Cosmic 313 was a study where PFS improved in intermediate and poor risk patients when we were adding a cabozantinib to a Nivo plus Ipi. So, what is your take? And you're already smiling कि मैं तो Nivo Ipi नहीं use करता मैंने हुने triplet दी गल की थी कि किवें आएगी यार.
No, I'm not using it.
Not using. Not
not
using.
using it.
Not
So
using.
it's very difficult to maintain all the three. So
मैं
I'm
सोचा
not.
भी कभी नहीं. So basically, poor risk patients in fact did worse in the OS. So Cosmic 313 was a negative study, no triplets for us. And just last minute on the ASCO GU 2026 update, where belzutifan, which is a HIF2 alpha oral inhibitor, which has now come into the fore, where one can see that belzutifan is finding its way up the ladder from a post 2 lines therapy to a second line therapy to a first line, that is the first progression. And now in the first line it has been seen that it is being added to a pembro plus lenva, and it has shown a PFS of 30 months. So where we used to see a PS of 15 to 16 months, it has actually doubled the PFS. Still a phase 2 study, but possibly in times to come there is adequate space for us to talk about belzutifan, right now available either on a compassionate basis or very expensive to import. But this is a new area that one is exploring in metastatic RCC. So possibly the debate will continue between dual IO and IO plus TKI, but one has to choose the patients wisely, the burden of patients, the performance status, and one has to really tell our patients in a very verbatim way that what could be the possible side effects, the quality of life issues, and if the patient is willing to actually undergo these things, then only we should be choosing a particular option for these patients. So I thank all my panelists, Dr. Kanika Sharma, Dr. Deepak Singla, Dr. Deepak Bharti, Dr. Mukesh Bansal, and certainly Dr. Ketan Dang for being there and graciously taking all the questions. Of course, we have to thank Dr. Sachin Gupta for giving us this time and space for a non-sponsored session where we could discuss everything, although there were some time constraints. Thank you once again. Back to the organizers. Thank you.
Thank you, Dr. Rajat. You have done an excellent job. And so this debate will still rage on. I don't think it is settled for ever. And of course, we have our individual experiences and preferences and ways to manage the disease. But we keep on learning as the new information comes, and we learn from each other as well. Thank you, all the panelists. We are delayed by nearly 20 minutes now, and I have to hurry up things. So I have dual task of being the presenter here for the next talk as well as the organizer. So to balance things out. So next, I'll just share my screen for this. Okay, so this is about, okay. Can you see this now?
Yes, sir.
Full screen mode, huh? This is better, right? All right. I hope it's fine.
Yes, sir.
Yeah. So this is about Ruby trial, survival impact of Jemperli in first line endometrial cancer. And so now this is another IO which is impacting the way we are treating many of the cancers these days. And this is a GSK sponsored session. And so now coming to ICIs and chemotherapy rationale. So we know that patients with primary advanced or recurrent endometrial cancer, they need additional treatment options. And ICIs in combination with chemo, so mainly we're talking about taxane carbo here, they may improve treatment response. So there is synergy of how the ICIs and chemotherapy work. And so due to increased mutations that promote anti-tumor immune cell reaction and increased tumor infiltrating lymphocytes, deficient MMR or MSI high tumors are more likely to respond to anti-PD-L1 therapies. So this information we are already aware about. And chemotherapy promotes anti-tumor immunity by inducing immunogenic cell death, which increases intratumoral T cell infiltration. Now coming to the biomarker testing, so especially for endometrial tumors, so nearly 1/4 of these tumors are deficient MMR or MSI high. And but dMMR endometrial cancer tumor, so they usually have a higher rate of recurrence and a mutation that increases the risk of Lynch syndrome and inherited condition that increases the risk of endometrial cancers as well. So this MSI-MMR testing is recommended for all patients with primary advanced as well as recurrent endometrial cancer. This is very important, especially endometrial. Now coming to Ruby Part 1 trial results. So in all comers with primary advanced or recurrent, if we see for all comers, and then we differentiate between two deficient versus proficient MMR. So all comers, so we combine dostarlimab with pegcilcarbo, and follow it up with maintenance IO versus placebo, right? And the endpoints are OS, PFS, and deficient MMR subgroup PFS, and response rates and duration. So here we are taking primarily FIGO stage 3 or 4 disease and including patients with more aggressive histology. So this is to be noted. So that carcinosarcoma were nearly 9% and serous adenocarcinomas are nearly 21% of this. And if we are taking stage 3A and stage 3C1, so these patients are with measurable disease. And also for stage 3C1 with carcinosarcoma, clear cell or mixed histologies, here non-measurable disease are also allowed. And then we have stage 3C2 or 4 patients, frankly. And so first, recurrent endometrial cancer with a low potential for cure by radiation therapy or surgery alone, and naive to systemic anti-cancer therapy. So now here is the diverse disease characteristics: carcinosarcomas, serous adenocarcinomas, and there were nearly 15% with clear cell, mucinous, undifferentiated, and mixed as well. But majority, of course, were endometrioid, nearly 55%. And if we look at the stage wise, 18% primarily FIGO stage 3, and then we have stage 4, and 48% were recurrent disease. Now for all comers, this is the 31% reduction in the risk of death with addition of IO. And the median OS, if you see, 44.6 versus 28.2. So additional 16.4 month improvement in the median OS versus only chemotherapy. And so this is for the aggressive histology, 36% reduction, nearly 12 months versus 8 months. So 4 months additional benefit. And more patients achieved an overall response rates with IO. So 70% versus nearly 65%. And median duration was 10.6 versus 6.2. So this is how the benefit is happening. Now for deficient MMR subgroup, median PFS was not estimable and there was 72%. So in DMMR, the difference is more significant. Hazard ratios are extremely good, 0.28. And if we look at the curve, it is going almost flat. So a lot of these patients are benefiting and are going to be long-term survivors. And median OS was again not estimable, and versus 31.4 months with chemotherapy. Again, the curve is almost going flat here, and 68% low risk of death with deficient population. So median OS is again significantly improved. And if we look at the overall response rates and duration of response, so median DOR was not estimable versus 5.4 months. So now this DMMR and MSI high subgroup is doing extremely well here. And if we look at the proficient and stable group, the 7 months difference in median OS observed with dostarlimab, and so the median PFS was nearly 10 months versus 8 months. So the benefit is less, but still there. And this is the dosage regime, 3 weekly initially, and after 6 cycles, the IO arm can be given 6 weekly. And so this continues. So this is the subgroup so analysis, PFS, OFS according to the molecular. So for deficient, we know these curves we have just studied, but for pole mutations, so the number of these patients is too insignificant, 5 by 400, and we may not deduce any significant thing from here. But for non-specific molecular subgroup, again, the hazard ratio is 0.77, and for OS it is 0.87. And for TP53 mutation, the hazard ratios are again good. 0.55 here for PFS and 0.41 for overall survival. And subsequent immunotherapy use, if we see, So of course, subsequent immunotherapy use is higher for the placebo arm, and in both the deficient and proficient and the overall group. And this IO used could be pembrolizumab or dostarlimab for the placebo arm. And PFS2 results are also better for deficient subgroup. So I was using 69% patients who received any follow-up anti-cancer therapy in the placebo arm. Some kind of IO would be, of course, used here. And this is the PFS2 results in overall and the proficient and stable population. Here again, I was using 50% of patients in placebo arm and nearly 55% of the patients in the overall population. So these are the adverse events. Again, if we can compare, so nausea, alopecia, fatigue, neuropathy, anemia, arthralgia, constipation. So these are again well matched. So no significant additional toxicities, and of course some immune-related adverse events like hypothyroidism, rash, arthralgias, and deranged liver enzymes could be seen. And there were serious adverse reactions, nearly 39% of the patients with dostarlimab. And the most common serious adverse reactions were sepsis and pulmonary embolism to the tune of nearly 3%. And so these are the general immune IO drug toxicities we encounter: some neurological, endocrinopathies, pneumonitis, cardiovascular, hepatotoxicity, renal, colitis, cutaneous, and musculoskeletal. So of course, all of us have to be very aware and cognizant of these toxicities whenever they come up. And some dose reduction is not recommended here. But any grade 3 events or grade 4, of course, we have to, for severe events, we have to discontinue the drugs. So this is how we manage. So grade 2, withhold, wait for the toxicity to resolve, and then reinstitute the drug. But for any grade 3 and 4 events, generally we avoid using the drug again. And especially if it is hepatitis or pneumonitis, and so we need to avoid using this drug. Same for nephritis. And so of course, with experience, we may try to reinstitute, especially for grade 1 and 2. But in generally for grade 3 and 4, and for myocarditis especially, even if it is grade 2, we need to permanently discontinue. And there could be some infusion-related reactions, and some fatal serious complications can occur in patients who received allogenic hematopoietic stem cell transplantation before this treatment has happened. And so we generally avoid IO drugs in transplanted patients for the same. So to just summarize this, so 16-month improvement in median OS for all comers, and this difference is especially great for a deficient MMR group, where median OS is not reached. It has got a robust trial design. Aggressive histologies are also included, and they are benefiting. And of course, we have some adverse events which we need to monitor and treat. And there was discontinuation due to adverse events in nearly 19% of the patients. And of course, not to be used in pregnant patients and lactating ladies and females of reproductive potential. And so this contraception is recommended here. I'll just stop here now. Thank you for, so in this lecture we have this much.
Thank you,
Stop
sir.
sharing.
Thank you
Do we
for the
have any
excellent talk.
questions regarding? Do we have time?
So, do we ask Dr. Ketan to start his lecture now, since we are running short of time?
Yeah.
Yep.
Good evening, sir.
Yep.
Thank you for this valuable opportunity to discuss this topic. With your permission, can I share my slides and start?
Yes, yes, go ahead.
Okay, right, sir. Are my slides visible?
Not yet. Your screen is there.
Yeah.
Yeah, they're coming up.
Right, sir.
Yes.
So, yeah. So today we will be discussing an important topic, which is not a great practice changing update, but still it is I would say, a practice enriching update, a very useful data which we can use in a select subset of patients. Not only it saves money, but also it includes a large population which was otherwise biomarker negative. So let's dive in. As we know, esophageal cancer is a global health problem, and esophagus incidence of cancer is in league with colorectal, just after breast, oral cavity, cervix, and lung. So kind of five ranks five, and it has a substantial mortality burden across the world and India. And we know we use this biomarker so often, PDL1. First of all, coming to this biomarker, there are several ways in which trials have tested this biomarker, which is CPS, that is the proportion of combined tumor and immune cells versus the entire viable tumor cells in percentage. And if you leave the immune cells out of this ratio, then it is TPS. And then there is a novel way, TAP, which is per area of the tumor, the positive immune as well as the tumor cells. So these are different parameters or methodologies by which PDL1 positivity is quantified in various trials. It is important to know which companion biomarker has been studied with which agent, because that can have a bearing on the decision and the outcome. So the problem with PDL1 is different cutoff, different antibodies, and different scoring systems. Also, there can be inter-observer variation, as well as heterogeneity in tumor, location, site of metastasis or primary from where it has been tested, and over time, the levels can vary. So this is a hot subject of investigation to with the aim to bring out uniformity and avoid confusion among us medical oncologists, whether the tumor, which biomarker parameter to apply, and accordingly, which agent to use. So coming to the unmet needs, so there is definitely a lot of unmet need in almost every cancer in India, and esophagus is one of them, where 50% of less patients may not survive for a longer period or have the opportunity to receive second line of therapy, whereby meaning that we should put the best step forward. And we know the limitations we have discussed of PDL1. And unfortunately, the PDL1 negative population, which is a large subset, that is restricted due of IO approval till now, until this data is discussed. We'll get to know how PDL1 negative population can also be benefited with this checkpoint inhibitor. So coming to the pivotal studies in advanced esophageal squamous cell carcinoma, most important of them, Keynote 590, where PDL1, anti-PD1 pembrolizumab was combined with cisplatin and chloropyrimidine. And it not only had esophagus adeno, it also had squamous histology. And we can see the results among the all-comer population and the PDL1 CPS 10 or more population. In fact, there was a lot of difference, and the real benefit was shown in the PDL1 positive CPS more than 10 subset, leading to its specific approval in PDL1 CPS 10 or more. Then coming to Checkmate 648, where nivolumab was combined with chemotherapy. And here again, the TPS, the formula we have already discussed. Here also TPS one or more, the benefit on right side, the Kaplan-Meier, we can see the difference compared to all comers. So all comers in both studies had PDL1 negative population. So it was benefit was mainly seen in TPS for 1% or more population, leading to its approval in this specific subset of esophageal cancer, which is advanced or metastatic. Coming to the toripalimab data, it's a novel molecule that has come up as a very handy and a very affordable checkpoint inhibitor. Coming to its phase 3 trial, that is Jupiter 06, the eligibility criteria were same, broadly the same as the previous two trials, that is locally advanced, recurrent or metastatic, and treatment naive for the relapsed or metastatic setting, and first line usage. So toripalimab was combined with paclitaxel and cisplatin. Unlike in the uh, uh, keynote study where it was cisplatin with chloropyrimidine, either capecitabine or 5-FU. So here the arm was the one that we more commonly practice for squamous cell histology, that is Pacli and platinum. And platinum also specifically they have used cisplatin, which requires much more stricter eligibility criteria, performance, cardiac, renal, and other function to be adequate. So much fitter population with Pacli and cis has been combined with toripalimab, followed by after 6 cycles with toripalimab maintenance. And that was compared with placebo plus chemotherapy followed by placebo maintenance. So chemo backbone is also a different and much more concordant with what we do in squamous cell histology. The endpoints, PFS and OS by blinded independent review committee, and other secondary endpoints like ORR, DOR, safety, and health related quality of life. So in the ITT population, so this Kaplan-Meier curve looked like the one that was seen with the checkmate and the keynote trials in the PDL1 positive population. They are similar to that. Even in the ITT population, we can see the hazard ratio is 0.58, very good confidence intervals, and an impressive p-value of 0.0036 with a median OS of 17 months versus 11 months. A 42% reduction in the risk of death.
Sir,
So
sorry to interrupt you. Kindly open
Yeah.
your camera.
What happened?
Uh, Sir, open your camera.
Maybe some picture clicking is required, you know, you may. You're mute. Ketan, you unmute also.
Right, sir. I hope all is going well. Is it okay?
Slides have gone. No, slides are not there.
Right, I will share.
Slides are not visible, sir.
Is it okay now?
Sir, make it full screen.
Actually, I'm not understanding what I need to do. If I share my screen, that my photo gets is not visible. So the solution is that you can share the screen from
Yes,
your
sir.
end if you want.
How do you share the screen?
Now I share the screen.
Sir, please stop sharing your screen.
Stop sharing screen.
Yes.
So now, can you please share the screen from your end?
Yes, sir.
So we were discussing the OS results of Jupiter 06. So
Pooja, make it slideshow. Yeah.
yes. So these curves on the entire ITT population are looking as if it were in that of the PDL1 positive population of other. Although, again, we don't have to make cross-trial comparisons. This is basically a Chinese molecule with a different population. We understand cross-trial comparisons should not be made. Different methodology, different chemo backbone. So yes, there are a lot of caveats. Next, please. So coming to the subgroup, whether it is age, gender, PS, prior radiation therapy, metastasis status, locally advanced versus metastatic or PDL1. Not only the arms were quite well balanced in both the arms, though also we can see that the PDL1 status, whether it is less than 1, negative, more than 1, less than 10, or 10 or more. In each of these subgroups, toripalimab is in fact doing much better. Although I would say that these numbers are small and these subgroups are actually not that powered to draw a definitive conclusion, but still they give us a lead. And the PDL1 data is actually post hoc. Next slide, please. So as I was saying, the PDL1 data, this is a post hoc analysis. It is not that stringent, strict trial criteria to draw an inference, but it is a very useful lead insights and which says that whether PDL1 is negative or positive, you see good results with this agent in this setting. Next, please. So the PFS efficacy again, the typical graph of a IO plus chemo combination. The curve starts separating in a few months and then the response is very durable. As we can see here, the hazard ratio was 0.58 with confidence intervals not crossing unity and p-value impressive 0.0001. Hazard ratio of 0.58, that is 42% reduction in the risk of progression or death. Next, please. Again, coming to the subgroups, we can see all these subgroups. We can see on the left side, it is favoring the PDL1 status as shown in the red colored box. Next, please. In the post hoc analysis, we can see the benefit in not only PDL1 more than 1%, but also less than 1% also has shown definitely a good improvement in performance, progression-free survival, 1-year PFS rate with toripalimab. Next, please. So coming to tumor response rates, they have been impressive. The overall response rate has been 69.3% versus 52.1%. So that is quite decent. Disease control rate, duration of response have all been better with toripalimab. Next, please. So in the post hoc analysis of the Jupiter 06 study, for the PDL1 negative subset, even in that subset, the ORR was 74.4% in the study arm versus 54%, thereby meaning a 20% improvement in the ORR in the PDL1 negative group with toripalimab, which is quite impressive in this population. So this tori plus chemo was associated with a meaningful PFS, OS, and ORR benefit over placebo plus chemo, even in the PDL1 negative subgroup. Next, please. So coming to safety, we have used it quite often, and there have been no major new safety concern. We can see from the table that obviously in the toripalimab arm, the immune-related adverse events are expected to be higher, which is the case here also. But as such, these are all expected side effects of IO, which we are all now well versed with their management. Next, please. So coming to this indirect way of uh, comparing the agents and the which set of chemo plus IO is performing the best for our patients. So this is a very beautiful and indirect way of doing a cross-trial comparison with a network meta-analysis. So this is a very important publication from Lancet, where there are systematic review and network meta-analysis have been done of various studies, and we can see on right the stringent criteria and the strict methodology that he have uh, done and excluded all the confounding and the not eligible studies to make a clear-cut idea of which of these regimens is better. And they have bifurcated chemotherapy into fluoropyridine-based FBCT and fluoropyridine-free FFCT. And then they have studied it with the IOs. Next, please. So this is a very complex graph, but it clearly shows that with regards to the overall survival, the combination of toripalimab plus fluoropyridine-free chemotherapy, that is Pacli plus cisplatin, is doing actually quite well in terms of overall survival with a hazard ratio of 0.57, as we can see. And they have included various regimens, Nivo plus fluoropyridine-based chemo, Nivo-EP, Pembro, other which are not available in India like Camreli and Sintili. Cislali has also been included in this network meta-analysis. And we can see in this important network meta-analysis that Tori plus fluoropyridine-free chemo is the best performer in terms of overall survival.
Sir, would
Next, please.
request you to conclude your presentation in 2 minutes.
Yeah. Next, please. So again, doing a cross-trial comparison, which we should not do, but what we will do if we won't have a table of compared results. Here we can see all of these agents beautifully. Their efficacy and safety has been showcased here. And in short, wherever the PDL1 is negative, it is better to use Tori plus chemo. Otherwise, we cannot compare cross-trial with different populations and different parameters. But for PDL1 positive subset, whether you use Pembroli, Nivo, or Kislali, that is based on the clinician's choice. And definitely, I would say each of these three agents are kind of similar in their efficacy for the PDL1 positive subset of patients. But for PDL1 negative, Tori has an edge, as we can see in all these parameters. Next, please. So because of these results, EMA has granted Tori approvals in combination with cis and paclitaxel for the treatment of adult patients with unresectable, advanced, recurrent, or metastatic esophageal squamous cell carcinoma in the first-line setting. Next, please. So this slide beautifully summarizes the approval. So use Tori irrespective of PDL1, whether negative or positive, it is efficacious as we have seen. Whereas tislelizumab is approved for TAP score of more than 5%, Pembro PDL1 CPS of 10 or more, and nivolumab for its TPS score of 1% or more. Next, please. So this is, we have all discussed that it has demonstrated benefit regardless of the PDL1 level with significant ORR, PFS, and OS benefit. So that's all. Thank you. Back to Sachin sir for any comments.
Yeah, thank you. Thank you, Dr. Ketan.
Right.
I think we are
Welcome.
short of time. Can't have
Thank you,
questions
sir.
now. One more lecture to go. But that was an excellent presentation, and you have also compared with the other agents and all. So newer IOs are here to stay and benefit our patients. We can definitely use this information in clinic. So I'll have another session. This is the last one to go. I'll request everybody to stay on for another few minutes. And Let me just share my slide. So which one is this? Okay. Okay, I hope you can see this slide.
Yes, sir.
Okay, now it's on slide show mode. Okay. So this is regarding IO-TKI. So close look in IMDC favorable and poor risk group. So now avelumab is little less used for metastatic RCC. I think people have various more other combinations which are their favorites, but maybe this data needs attention. And okay, so this is how the first line metastatic RCC treatment and IO combinations have evolved over last 2 decades. So starting from interferon, interleukins, and sorafenib, sunitinib, temsirolimus, anti-VEGF, bevacizumab, pazopanib, tivozanib. So we have a lot of TKIs. And then with the advent of IO drugs and combination, and we have a lot of discussion today evening regarding dual IO versus IO TKIs, and all these trials are there which we are using. And so I'll be concentrating here on avelumab plus exitinib data, which is Javelin Renal 101, which is little less discussed, but it is a very important data we need to understand. And so Javelin Renal 101 is a phase 3 trial of avelumab along with exitinib, and it has got a long follow-up. So untreated advanced RCC clear cell randomized to Bevensure, which is avelumab 10 milligram per kg 2 weekly with exitinib versus sunitinib. So sunitinib was the standard of care drug, and so all these trials were pitched against sunitinib, and same happened in this trial also. And the outcome measures were primary endpoint of PFS and OS in patients with PD-L1 positive tumors, and PFS was in the overall population, and overall response rates and duration and time to response were also studied. So if you look the follow-up duration of IO-TKI trials, so Javelin has got one of the highest follow-up duration of nearly 74 months. So this is how this data is again very important. And so there was, okay, did I skip some slide? Okay, so significant median PFS benefit with 34% risk reduction and almost double overall response rates compared to sunitinib. So 14 months of PFS versus 8.5, and so then nearly 5.4 months improvement. 60% versus 32% response rates. And so with longest follow-up, higher median OS with curves continue to separate till the end. So here we can see the curve remained divergent, and median OS 45 versus 39 months here. And so the final OS readouts will better reflect the effect of later line treatments here. And these are the treatment related adverse events. So diarrhea notably higher than the diarrhea, hypertension, fatigue, and hand-foot syndrome. So some of these are due to the TKI arm, but of course diarrhea is notably higher as compared to the single agent sunitinib. So in RCC, one size doesn't fit all. So we have a lot of these trials which we need to, some cross trial comparisons can be done. Favorable, intermediate, poor risk, we divide our patients into to decide which drugs to be offered. So coming to the IMDC favorable subgroup, and if we see there is unclear OS benefit for all other phase 3 first line IO-TKI studies in favorable. So keynote, the curves are overlapping in favorable. In checkmate 9ER, which is Nivo Cabo, again for favorable group, they are almost overlapping here. And for clear data, which is Pembro, lenvatinib versus sunitinib, again the curves are almost overlapping each other. And it's here where this avelumab axitinib stands out as the IOTK in the favorable risk. If we see the OS, it is 58% reduced risk of death, median OS not reached versus 41 months in the TKI, and same for PFS, 25 months versus 14 months. So OS PFS benefit in favorable IMDC with IO and TKI. So which was not there with the other trial. So better median OS hazard ratio in favorable risk compared with other. So this is again a cross trial comparison, but this is important to look at median OS 79 versus 65, and hazard ratio is 0.73. Overall response rate is nearly 76%. So this stands out in the favorable risk category. And coming to the poor risk, here again it stands out. Median OS 21 versus 11 months, hazard ratio 0.58, and the PFS investigator assessment for poor risk 8.7 versus 4.2. So this is how this is in favor of avelumab axitinib in the poor risk also. So this is the first line IO combination trials in metastatic RCC. If we divide into favorable, intermediate, and poor, the Javelin Renal 101. So this stands out in favorable as well as in the poor risk with 76% and 38% response rates. And so the overall, as we have seen this data in the favorable profile as well as for the poor risk, there is good benefit seen. So, and there is also Indian real world data, although the number of patients are not too high, it's about 54, median PFS 13.2 months and median OS nearly 37.6 months here. And response rates nearly 100% in favorable and 52% in the poor risk. So this showed good efficacy. So if you have to select treatment across risk groups for favorable, avelumab axitinib or TKI alone, so they favor. And for poor risk, we have avelumab axitinib, and of course, there is a strong dual IO data for intermediate and poor risk with Nivo EP, and we have other TKI IO combinations as well. So patients are living longer, so safety, quality of life is also important. If we compare the adverse event profile, then we find that avelumab and axitinib, the number of adverse events are actually low. So TRA grade 3 is also less, discontinuation rate is least, steroid used to prevent toxicity is also least, and the pneumonitis rate is also least as compared to the other trials with Pembro, Nivo, and EP. So now we have some data with sarcomatoid, dialysis, and acute kidney injury patient. So if you look at the sarcomatoid patient here, also the response rates are higher, 47% versus 21. And so this stands out in this sense. The median PFS in sarcomatoid is also improved with a hazard ratio of 0.57. So clinical benefit is also there in the aggressive histology patients. And there is also some data to suggest that end-stage renal disease and hemodialysis may not be a contraindication for use of avelumab axitinib combination. And indeed, patients can safely benefit from such combination therapy. And it's also safer with a low risk of acute kidney injury also. As we saw, the adverse events are less, so the renal adverse events are also less with this particular combination. And first line avelumab axitinib favorable efficacy across age groups, including patients who are more than 75 years. So this is, if you look at the 75 years group, the overall response is 42 versus 22, and with some impressive CRs as well. And pulmonary immune-related adverse events of PD-1 versus PD-L1 checkpoint inhibitor. Here we see that Nivolumab had the greatest pneumonitis events, and avelumab having the least exacerbations, and Pembro had the greatest sarcoid events, followed by nivolumab, with avelumab producing the least event. So this toxicity data goes in favor of avelumab. The adverse events are significantly less as compared to other agents. So we have to balance between efficacy and safety, and this particular combination stands out, and especially for favorable risk group with better hazard ratio, poor risk group, 42% reduction in death, good long-term safety data, and also good for patients undergoing dialysis and elderly and sarcomatoid component. So finally, it strikes a balance of efficacy and safety. I think that's all we have to show in this presentation, and maybe we can.
Thank you, sir. Thank you for your excellent talk, and I invite you for the closing remarks.
Yes, we had excellent, nearly 2.5, so nearly 3 hours deliberations now at the end of this evening, with some excellent panel discussions and sharing of data. So I hope everybody has benefited with the latest data, and since it is we are beyond time and everybody is waiting for dinner, I think we should stop here. And let's all join together again tomorrow for nearly 2.5 hour session of for the remaining discussions. There are many exciting sessions tomorrow as well. So thank you, Horizon team. Thank you, Pooja, Daud, Ekta,
Thank you, sir.
Tarunji, and everybody behind the scene, whoever is working here, and all my pharma colleagues and industry support we have got for this session. Thank you, everybody. And let's all join together tomorrow for another exciting session. Thank you and good night.
Thank you, everyone.
Thank
you,
you and
everyone,
good
for
night.
joining. Good night, everyone. Good night.